mpenzi wangu, rafiki yangu, nimekuchagua wewe kupea mahitaji nilikupa, hata wazazi walikubali. Hivi mbona unaniacha? Sielewi kosa gani nimefanya, sielewi mambo yako siyaelewi. Kama wanipenda mbona unaenda, mbona unaenda? Inasikitisha, inavunja moyo kupata habari eti unaenda. Mpenzi wangu, tafadhali usiondoke, baki na mimi. Mbona unaniacha? Sielewi kosa gani nimetenda, sielewi mambo yako siyaelewi. Kama wanipenda mbona unaenda, mbona unaenda? Hivi mbona unaniacha? Sielewi kosa gani nimetenda, sielewi mambo yako siyaelewi. Kama wanipenda mbona unaenda? Hivi mbona unaniacha? Sielewi kosa gani nimetenda, sielewi mambo yako siyaelewi. Kama wanipenda mbona unaenda, mbona unaenda, mbona unaenda? Watazame hao wenye wivu mbea, eti wanasema huwezi kuoleka. Matumbo yanawauma wakituona pamoja, achana nao, hawawezi tutenga. Ningependa tu kusema moyo wangu umeshauteka, nimeamua kukupenda na nitakupenda we kabisa. Nakupenda, nakupenda, sitokuacha, sitoenda, niamini naposema nakupenda, 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 sitochoka mikunena, niamini naposema nakupenda, nakupenda, nakupenda. Nakutaka wewe uwe wangu wa moyo, kwangu uwe Julia, kwako niwe Romeo. Tumuombe Muumba abariki huu chumba, atupe baraka tuwale watoto. Ningependa tu kusema moyo wangu umeshauteka, nimeamua kukupenda na nitakupenda we kabisa. Nakupenda, nakupenda, sitokuacha, sitoenda, niamini naposema nakupenda, 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 sitochoka mikunena, niamini naposema nakupenda, nakupenda, nakupenda. Pendo letu ni tamu, ni asali. 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 Nakupenda, nakupenda, sitokuacha, sitoenda, niamini naposema nakupenda, 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 siutani naposema sitochoka mikunena. Nakupenda, 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 nakupenda. Pendo letu ni tamu, ni asali. 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 Nakupenda, nakupenda, sitokuacha, sitoenda, niamini naposema nakupenda, 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 sitochoka mikunena, siutani naposema nakupenda, 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 nakupenda. Good morning, ladies and gentlemen. Good morning, ladies and gentlemen. Acha nisimame ndo mnione vizuri. Si tumekaa ya kutosha. Tusimame tufanye a little exercise. Just a little exercise. Please just stand up. Shake the exhaustion away. Yes. We're going to do a song that is sung by preschool students. Ndio. Head, shoulders, knees and toes. Na tufike kwa toes, sawa? Ndio to stretch. Aya, twende. Head, shoulders, knees and toes. Knees and toes, yes. Knees and toes. Head, shoulders, knees and toes. Eyes, ears, nose and... Na maringo sasa. Head, shoulders, knees and toes. Knees and toes. Knees and toes. Head, shoulders, knees and toes. Eyes, ears, nose and mazunguka. Head, shoulders, knees and toes. Knees and toes. Knees and head, shoulders, knees and toes. Eyes, ears, nose and... Now clap side to side. Zimbole, 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 oh, zimbole, oh, zimbole. Then we do this. Pop, 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 pop. Hey! So, hey! Yes, I am. Let's practice that part. Pop, 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 pop. Ay. Hiyo stress yenu nisioni ikitoka. Hey, kila mtu. Again. Aya, twende. 1, 2, 3, let's go. Zimbole, zimbole, zimbole. Bwana nipe pesa, watoto wana njaa, lakini mke wako anapenda kutangatanga, hata majirani wamechoka kumuona. Wao husema fungeni milango, anakuja. Bwana nipe pesa, watoto wana njaa, lakini mke wako anapenda kutangatanga, hata majirani wamechoka kumuona. Wao husema fungeni milango, anakuja. Watu wote wa Nairobi wakuona kila siku, ukiingia nyumba zote za changa kali sana. Tafadhali bwana rudi, watoto analia sababu mke wako ashazoea kutangatanga, hata majirani wamechoka kumuona. Wao husema fungeni milango, anakuja. Wa Mombasa wakuona kila siku, ukiingia nyumba zote za changa kali sana. Tafadhali bwana rudi, watoto analia sababu mke wako anapenda kutangatanga, hata majirani wamechoka kumuona. Wao husema fungeni milango, anakuja. Oh, Bwana nipe pesa, watoto wana njaa, lakini mke wako anapenda kutangatanga, hata majirani wamechoka kumuona. Wao husema fungeni milango, anakuja. Watu wote wa Kisumu wamuona kila siku, ukiingia nyumba zote za changa kali sana. Tafadhali bwana rudi, watoto analia sababu mke wako anapenda kutangatanga, hata majirani wamechoka kumuona. Wao husema fungeni milango, anakuja. Watu wote wa Nairobi wakuona kila siku, ukiingia nyumba zote za changa kali sana. Tafadhali bwana rudi, watoto analia sababu mke wako anapenda kutangatanga, hata majirani wamechoka kumuona. Wao husema fungeni milango, anakuja. Wao husema fungeni milango, anakuja. Wao husema fungeni milango, anakuja. Mtupigie hata makofi. Asanteni.
Good morning, ladies and gentlemen. Did you say hi to your neighbor? I want to receive your greetings after you have shared with your neighbor. Let's say hi to somebody next to you. Get to know who they are, where they are from, and ask them whether they had breakfast. If not, lift your hand on their behalf. Oh, okay. seated here. Please, at that booth there, then go to that booth. You will have your breakfast there. There is somebody should give you a book. You have breakfast in you. All right. Things have done good. Those one first that are not taking breakfast, please go to the booth there and you will get your here. Have you said hi to your friend? All right. So we want to begin our program, and I want those that are a bit behind there, if you can make some steps to the front. We are the guests, so nobody else is expected here, more important than you. So please make your step a few rows to the front so that we allow the back seat for those who will be coming later to come and sit there. Having said that, we want to open with a word of prayer so that we can have our day blessed. Are you ready for prayers? Okay, shall we bow down for a word of prayer? We thank you, Heavenly Father, for giving us yet another opportunity this morning. We pray that your grace rest upon us today. Thank you for journey mercies from the far and wide places that we have come from. We ask you to bless our day and watch over us throughout this day. Give us a successful day. In Jesus' name we pray. Amen. Right, we will have a series of activities again today. We want to see if we can do a number of things during the morning session so that we can break and have some time for the exhibition and a number of things that we wanted to do. So you will have adequate time to visit all these booths and make the necessary transactions that you need to. So we will try to compress a number of things early in the morning when we are still fresh. What we are discussing today is the digital health. Digital health. Hey, it's mouthful. And we want to hear all about that. We have people from the DHA that will be here. We have people from the private sector, and we want to put our minds together so that we can understand all these things that are happening in the healthcare space digitally. So we'll be having a panel here, but before that panel, I want to invite one person. Ama nipatie muziki moja. Hao wanakaa kama wajamaliza playlist. You have one more? Mko na kigosho? Bas. Let's have one and then I'll bring in my kid.
For this one, you'll all have to stand because you can't go to heaven while seated. Tafadhali tusimame. Makofi ya juu, makofi ya chini. Twende. Jikaraga jothererie thumbi yakwa njeru ena thiri muingi Tora togo mame shoderirie. Makiuma the nao tani muinge deviaga de waroho. Gahoyaga de waroho. A bit to the right. Gagoshaga de waroho. Left. Jondo niwe moto ngoria wakwa. Deviaga waroho. Gagoshaga de waroho. Gahoyaga de waroho. Jondo niwe moto ngoria wakwa. And we are going to repeat until everybody follows suit. Kuna jeshi iko pale wanatafuta, but they are still looking for their right feet, the right knee. This is the right foot, sio hivi. Deviaga deveine waroho. Kaoshaga deveine waroho. Gakenaga deveine waroho. Jondoniwe mutongoria. The last one. Deviaga deveine waroho. Kaoshaga deveine waroho. Gakenaga deveine waroho. Jondoniwe mutongoria wama. You are good people, you'll go to heaven. Reverend, kuja uwaombe waende mbinguni sasa. You have done the marination.
All right. The first person I want to bring to us this morning, before we start doing the digital things, I want to bring in one of our key stakeholders, and they have an interesting subject that we need to know, and then we venture into other things. Now, I want to bring in an organization called ATAN, and this morning, ATAN is represented by none other than our friend Sam Jairo. He's going to present to us about what they do, and just to open your minds and to see where your facility can come in terms of what they are doing. Karibu sana. Can we give a round of applause?
We give you 50%, but it is capped at around 20,000 shillings per month. And then we allow you to be able to remove the problem of looking for talent through HR. Some of the key roles that we help you with include finance, IT, operations, and things like that. And so if for any reason you have received an email from RUPHA asking you to express your interest about this program, I would like to encourage you to please take full advantage of it. It is still in the pilot phase. Should it receive successful implementation, then we will figure out how to scale it up across different industries within Kenya. But I think it would really help you if you were to consider taking up one of Ethan's offers. So the last slide just shows my email address in the event you would like to reach out to us. This is just the model of how it works. There's a partnership onboarding, there's the employer and the role setup, there's a matching and the placement, and the monitoring and the financials. I think if you focus on point number 2 and 3, which is ideally where you as an institution let us know what are the key areas that you need assistance with. You give us a job description. We have a pool of candidates whom we have received from partner organizations like universities, and we put your JD against the CVs, and we give you a short list of candidates that you can interview. Once you have your short list, you confirm, we sign a contract with them and with us, and we begin the invoicing and the monitoring process. It's not a simple process, neither is it complicated, but it is also meant to ensure that as you onboard these individuals and these candidates, you're not only providing employment, but you're also helping your business processes. So yeah, so just the last slide. This is my email in the event you would like to reach out. That is our website. Like I've said, we have already begun operations with your CEO. So in the event you have any question, please reach out to RUPHA, and we'll be more than happy to help you, to help your businesses thrive. Thanks.
I think that is a great solution. Okay. That's a great solution, and one of the things that probably at the end of or during the break, you either see our friend Sam or our CEO, they'll be able to link you up with that solution. Very great one. You can have someone work for you. If you give a stipend of 20,000, they will pay 50% of it. It will help you reduce your costs, and that will be a great thing. Thank you so much, Sam and Atan. We appreciate that. Without much ado, it is now my pleasure to bring in our chairman, Dr. Brian Lishenga, to carry us on from that point. Thank you. Let's appreciate our chairman.
Thank you, Vice Chairman. My task is very simple. Good morning, members. I think one of the things that Sam skipped to say, and I think he didn't emphasize that. Maybe let me emphasize this so that we as facility owners can understand the context. We are all struggling with issues to do with human resource. We are all struggling. I know that because of the cash flow challenges we've had and all these issues, there's a bit of a struggle, you know. In fact, one of the things we've seen in our surveys is that there's a high rate of turnover of employees. So you're losing out a lot of employees, and we saw especially like nurses, but also administrative staff, clinic officers, all these things. So, and the background problem here is the cash crunch that you have been going through. Now, what Atan is simply saying is that we have a very big labor market out there of people who are qualified. IT, accountants, nurses, clinical officers. They need an apprenticeship, an internship to get into the job market. So this program is very simple. You could be needing just a simple management consultant, somebody to help you balance books. You know, there's that assignment in your office that you have been postponing forever. You just, I will get someone to do it. I'll get someone to do it. Your accountant is busy. Maybe you don't have the IT person you want to hire is too expensive. The Atan program is very simple. They will get you an intern, if it's an IT, accountant, whoever, somebody very qualified, very good. And they will pay half the stipend for you. So if you are going to go to the market and pay somebody 30,000, you know, to do a job which you might need 6 months or 1 year. So here is a partner who's saying, we will take half the cost because we are trying to promote apprenticeship. So that is the idea here. And I think all of us need somebody like us. You can think somewhere in your department, somewhere in your hospital, there's probably a gap somewhere where somebody can step in. And so it's a win-win. For the intern, they get to get real life experience, real on the job experience. Maybe, who knows, you might even end up absorbing them if they are really good. But for you, it's win-win because your HR expenses are at least half taken care of. So I think this is a brilliant thing that we should consider. And please see Cynthia, our CEO, or see Sam for extra information on this. So I will not take too much time. We have a very important discussion around digitization. So this morning session was a digital conference, and we are very, very honored that the Digital Health Authority graciously accepted our invitation to come and discuss with us this. But not only them, we have a lot of our digitization partners who are here with us today, and they will be sharing with us what the vision for digital health looks like. Now, the person I want to introduce to make our keynote address, and she's going to make just a few remarks, Dr. Joyce Omishwe is a very good friend of mine. She will tell you what she does at DHA, but we joined the university together. It might surprise some of you, but that was in 2000 when we were first years at the University of Nairobi. She ended up in the digital space in Ministry of Health. I ended up in RUPHA. What a world, eh? But she is a champion for healthcare facilities. She is passionate about us as healthcare facilities being able to serve patients, because all this thing is about the patient finally. So I want you to look at it from that lens, that you are listening to somebody who fights for you, who cares about how your business does, and who is trying to make a difference in the healthcare system. So, without saying much more, my very good friend, Dr. Joyce Omishwe, karibu sana. Let's give her a round of applause. Do you want to use there or do you want to stand?
Don't know.
Which one do you prefer?
It depends.
Okay.
I think thank you. So good morning. Hamjambo. Bonjour. Anyway, I would have gone now through the various tribes and seen how far I'll go, but allow me to say that we are really excited here. Thank you, Dr. Lishenga. Thank you, RUPHA. Thank you, RUPHA family, and to all the stakeholders that we have in this room. As a digital health agency, we do like coming and meeting with the stakeholders who we are working with in the digital health transformation in this country. At the Digital Health Agency, I am currently the Director for Certification and Standards. I have been at the agency for about 2 years, okay, 1.5 years, deployed from the Ministry of Health to set up the agency, operationalize it, and so far, so good. It's a small agency. We are still trying to get our feet up, but we've caused quite a storm. True or false? I don't know whether it's a good storm or a bad storm, but when we are doing a lot of innovations, a lot of creativity, there is bound to be a storm. I think the most important thing is to always keep on looking at where we are heading to, and if we are getting closer to our goal, then that storm is not so bad. But if we are moving further and further from our goal, then we need to always keep checking why we are not moving towards our goal. I think that is the spirit that we like to adopt at the agency. I'm standing here on behalf of the CEO. He is called Engineer Anthony Lenayara. He's been with us for quite a while. He's a substantive CEO. And he would have loved to be here, but he felt like this was going to be a very technical meeting. Plus, he's also doing other things that are around digital health transformation, so he asked that I come. So I come after a very interesting presentation that has just been done that was dealing with pain points, but from a human for health, no, HRH. It's called what? Human Resources for Health discussion. And it draws me back to a conversation we had with the WHO team a few weeks ago, where we were talking about the National Health Workforce accounts. And yes, this is something that is done annually, and we are able to tell which cadre is unhappy, for example. And the nurses are unhappy. They are leaving so fast, and it is evident in that when we looked at the data. But the question I asked the WHO team was, do you have to wait for 12 months for you to come and tell us something that we know? We now want to know why they are leaving, okay, where they are going, and what is happening when they leave, okay? And which are the cadre, when you look into the future, can you predict which is the next cadre that will be unhappy? Which is the cadre that is happy, for example? And that is when we started talking about digitization, so that we have real-time data by county, by cadre. We look at the numbers and we are able to make a decision. So that was a pain point that was being solved using the digital health solutions. So that now takes us to why DHA was called to do this keynote address. The title we were given was From Hospital Pain Points to Digital Health Solutions. I think I've already finished the presentation, yeah? Using the previous presenter. So the Digital Health Agency, just to start, so that we can all know what we do, our mandate is well explicitly provided for in the Digital Health Act. And from a layman perspective, our work is to digitize the health sector. Now, we know the health sector has certain pillars. If you read WHO, we know the pillars. I've just addressed one of them, that is the HRH. We also know service delivery is another pillar. We know financing is another pillar. Which is another pillar? Which other pillar do we know about? Do we have a roving mic? This is not going to be a keynote address. It's going to be a responsorial address. We have the one that we keep on talking about, the HPTs. Watu wakienda hospitali na wakose madawa, are they happy or not happy? They are unhappy, okay? And then, of course, we have governance and all those other pillars, the building blocks, that is what they are called. So from a hospital perspective, I would just like 3 or 4 people to tell me what are these pain points that you see Digital Health Agency coming to solve with digital health solutions, because that is what our mandate is. We digitize the health sector. So we look at those pillars and we look for digital health solutions to solve, to deploy to solve those pain points. So just so that I can get a feel, I think the band did a really good job keeping us company. We have danced, but now let's get into some technical discussion. 3 or 4 pain points, or even 2. Who can talk about 1 or 2 pain points? Ndio tukue pamoja. You know, wako sawa? Ama maybe hamuna pain and a point.
Wacha chairman wao waongelele rejected claims. Si vitu kama hizo. Sasa muendelee. Hiyo ni list moja.
Sasa wewe umewaelekeza one spot.
No, sasa muende kwingine. Hiyo ni yangu.
Thank you very much. I'm Muriuk from Minas Medical Center. Pain points are multiple, but I will just mention a few. Sometimes you find the biometric refuses to work when the queue is long. Then the worst part is delayed payments, no payments, and also that one is a very strong pain point. Thank you.
Okay. Please note all those pain points that you've described are just for one building block, the healthcare financing.
Morning, Masiaga Joseph from Mamo Hospital, Migori County. When we started with the SHA, we used to see what you expect, what is approved, what is sent for payment, those areas that currently they are not being seen. You can't know what you're expecting, how much you've been paid, how much is remaining. Reconciliations, surely it is a pain point.
Okay.
Yeah.
So for my purpose, I'll register that under data for decision making, as much as it's very related to healthcare financing. Dr. Lishenga, why did you start this particular building block? So you don't have a pain point in terms of service provision, in terms of HPT. Thank you.
Yes, good morning. I'm Paul Kitala from Kana Hospital. One of the pain points is that you DHA people, your communication to the share offices people who are handling matters of customer care, there is a bridge that when you visit the offices, you'll find there is nothing they know concerning maybe the returns, the sendbacks on that. And also in case of failures in DHA, or maybe you are doing something on DHA, maybe system update, I know this is the time of implementation, and when you are doing implementation, there are a lot of things that entails with system breakup, maybe system not functioning. You don't also communicate. It's only, since you started, I only saw one communication that you made, that there is a system maintenance that you are doing. But on other times, you'll find us holding clients for long. Even there's a time we hold client for a full day, because they are not able to pay cash, and they'll have to wait until the system works. So there's that bridge. The customer care people at the NHIF offices, they are not aware of what is happening. And in case you question them, they are telling you, just write an email to DHA, and yet when we write those emails, there are no response. It will take forever for you to respond to those emails. So you find there is that gap in between you DHA people and the SHA people that you have deployed in the SHA offices. Thank you.
Thank you. Now the pain points have started.
Good
trickling.
morning.
Thank you.
Good morning. My name is Margaret from Rosemeg Medical, Meru County.
Where is she?
Right.
Oh, okay.
Yeah.
Thank you.
So our pain point is where the system is the doctor in itself. Like it decides what you should treat, how you should treat it, and how you should admit your patients. For example, if a patient comes in with multiple conditions and you raise like a pre-authorization, it would only capture that. After your lab test and you see there are other underlying issues, it is not able to like address that in terms of payment or granting you go ahead to like treat the other conditions that you have detected. So the system should not be the doctor.
Sorry, thank you. So you said you're from Meru?
Yes, Meru County.
Meru County?
Yes.
Okay.
Yes, my name is Kiambi from Meru County again. I think Meru people eat Mera and then they are very well. I am from Mitungo Hospital. Now, the other pain point is when somebody comes to your facility or within a period of 72 hours, he or he inarejectiwa because alikuwa mahali pengine, for example, due to a similar problem. I have no way of knowing this person was in another facility so that we discuss. The only way I will know that alikuwa kwa another facility ni when the claim is rejected and I'm now following it up. Make it easy so that we reduce the complaints. Thank you.
Okay, thank you, sir. The last pain point. Not the last one, because there are many, but yes, for purposes of this discussion.
Yes, again, now, I've been going through the sandbags that we receive as an hospital, and one of the other challenges that we are facing is that during your rollover of your system, when maybe you are checking on a claim, you'll find maybe someone we treated an inpatient client today, and when now you are doing your rollover, you'll find that the client, maybe we admitted the client on date 6, and the billable period, we billed the client on date 6, and then now his cover was ending on date 9, and then he pays on date 13. You'll find that the claim has been rejected, saying that this person started paying on date 13. The period of payment is from date 13, so we cannot pay you. And you find that is not our problem. Maybe the employer delayed to pay the policy by 1 day or 2, and you'll find you are rejecting it instead of accepting it. So that is another issue that we are facing on returns.
Okay.
Hello, my name is John from Nairobi, Kasarani Maternity.
It's a bit confusing because we are directing our claims issues to Digital Health Authority. Our contract is with Social Health Authority. So who is running what? It's a bit unclear.
I will provide that.
Good morning. My name is Robin from Kidano Store, Mombasa. I'll still talk about the same issue. Communication is an issue with DHA and SHA because we are getting so many new changes coming onto the system without communication. We get claims being rejected on the basis of maybe new things that have been required and there's no communication. I wish DHA, SHA, and Ministry should improve on communication. Next is about the system. The system is a bit cumbersome because we expect the system to make our work easy, such that it's seamless. Communication between the providers is easy, but the current system is not so friendly because there are so many things that you have to input. Patient has to go back and forth, put OTPs, biometrics, check in, check out. It's so cumbersome for the patient.
Okay, thank you.
Thank you. My name is Godfrey Karuru from Solaya Hospital. After the staffs have seen client from SHA, and the patient have come, and you have treated them. Actually, they have filled everything, and they have been discharged, and they have signed out. Only to maybe, after you look at the records, you have done like 100 clients to SHA, and they have been completed and submitted. But when you look at the portal of what you are supposed to be paid, you find that you have seen 30 clients. When you ask them where are the rest, they tell you that those clients that you saw, we sent them an SMS, but they did not say that they were treated. So clients are receiving SMS to ask them, were you treated in Solaya Hospital? Maybe these people are busy, or they don't even know about it. Either they knowingly or unknowingly. Then you find that you have not, they are not in your numbers. So at the end of the day, you end up being paid for that client when you have seen about 200 people. That's a great pain point. Thank you.
Thank you. We can now close it.
Hi, Doc.
Yes.
Good morning, everyone. My name is Tapens, Kentuck Medical Center, Mlolongo. Daktari, my question is, there are those instances that you just wake up and you find there are changes in portal without prior communications. So for instance, on the 4th of April, there are changes. When a patient comes, after you initiated the visit, you've done, patient has gone home. By the time you're going to send that claim, you'll find the patient is expected again to do a biometric. And it wasn't really communicated to us. So calling patient to come back and have their fingerprints or we discharge, this for level 2 facility. As I think this is not the first time it's happening, and I believe it's not in order that two people are in contract and contract is being manipulated or managed by one partner. That's a breach. Number 2, concerning the DHA, there was an instance we've been having issues with biometric system failure. So at times you try to put your machine in another computer, maybe in another consultation room if the reception was is delaying. And so I noticed when we downloaded the health ID in another computer, that's for level 2, you realize it automatically, the other computer kind of become inactive. So in a level 2 is like you cannot download the health ID in 2 computers.
So I did a call to DHA, and the response I got is for level 2, you don't consider having 2 computers or 2 biometric points. I don't know whether this decision can be reconsidered. My last is concerning the patient having their biometric both at admission and discharge for level 2, especially PHC. At MCC, so many patients. Will you have a better way of handling? Because now our system is not becoming efficient. It brings a lot of confusion into that. Last but not least is for claims that is rejected, maybe, just my thought. Like I saw some rejections, the comment was missing claim, which is valid. Is there just opportunity to give us a chance to attach that claim? What do you think? Thank you.
Thank you. Give yourselves a clap.
Good morning.
If
The
we
last
continue
one,
like
please.
this, we will not continue.
Kindly.
Okay, Sawa, thank you.
Yes, on 2nd of April, we woke up to a consent where we were needed to sign from the system. And the moment we signed, it started deducting 2% on every claim form. My worry is we are quick to deduct the 2%, but again, the aging is overwhelming. Where are we balancing in terms of our payments and in terms of reconciliations? Thank you.
Okay, thank you. So thank you. Clap for yourselves. Let's clap for ourselves. That was quite engaging. So allow me to give a background based on the pain points that you've talked about. And many of them are about the system that we are currently having for SHA. So for digitalization, digital health is more than SHA. Let's just start from there. So I would like you to think back at your health facility and identify which are these places that you would want to digitize for increased efficiency. How many of us come from facilities that are currently using a hospital management information system? Is it end to end? Is it end to end? It's end to two only, out end to end. And the rest, it's patchy, okay? Yeah? So that is one of the things that the Digital Health Agency is interested in. Because a lot of the things that you've raised today, if we now had those hospital management information systems onboarded onto what we call the digital health superhighway, and I'll be talking about what that means, then a lot of the things you are describing would not be happening. But why do we find ourselves where we are? So we have facilities in Kenya. Currently, we have about 16,000. 10,000 of those are SHA contracted, or rather are offering services under SHA. About 7,000 are public. FBOs are about 800 going to 1,000, and the rest are private. RUPHA encompasses the private, the rural private facilities. So you are in the other, let's say, what, 8,000. Now, facilities are at different stages. We have facilities that are fully digitalized. End to end, there is practically no paper in the clinical journey. Once you get in there as a patient, you are moving from one place to another with no paper. But we also have facilities where it's hybrid, okay? And we have those that are manual. So the system that you know as SHA system, what we call the provider portal, is a temporary solution that we brought to make sure that all facilities, whether you have a digitized system, whether you are hybrid, or whether you are manual, you are using the provider portal. The only thing with the provider portal is it makes you do things either double work, that is for those people who have
the HMIS. So you come from this system, then you jump into this system. You could be jumping between two computers, or within the same computer you have two windows open. Or if you're manual, then you're operating retrospective data entry, which is what a lot of the people who have stood up here and said, we woke up, we found discharge OTP or discharge biometrics has been put, and we got stressed. Because those, I can tell, are either at hybrid or at manual. They are at that level, and that is why that is really stressing them. So the Digital Health Agency, the future is this, that all facilities will be digitized, end to end. All facilities will have a hospital management information system. And then for SHA specific, and we are hoping that even other insurance agencies will at some point look at how we are doing with SHA and also seek to get the same. For SHA specific, we are going to have the billing module in that HMIS being something that looks like the provider portal. As long as we are doing things double or doing retrospective, in comes our problem. So that is number one. So it's good to always understand the future, where we need to be versus where we are struggling. The second thing is, during the NHIF times, were we having a discharge biometric or OTP? Was it there? So why are we surprised today? The reason why we are surprised is because at that particular time, NHIF, was it being done at level 2, level 3s? Was it being done in dispensaries? It was being done in dispensaries. Well, yani people could go to a dispensary with an NHIF card and they're sick. In a dispensary, at some point. So, okay, it's a yes, no, some people are not so sure. Okay? But the idea is a lot of facilities that are level 2, level 3 is the first time that they are really dealing with healthcare financing in the manner that we are dealing with SHA. True or false? Okay? So some of these things are new things to them. For a facility, you see, whenever I hear, why do we have a discharge OTP, discharge biometric, I'm not hearing from the higher level facilities. Because our wamezoea, it's been part and parcel. Let us agree, a clinical encounter has to have a start and an end. The problem is how the system is facilitating us to do that. I agree, the system has not been stable for a couple of, it's been bad for the past few weeks, and we know the reasons why. As DHA, we are working very hard with our partners to ensure that there's stability, and perhaps that is why that issue is coming up. So the issue should not be that we don't want the discharge OTP or the discharge biometric. The issue should be, make this system stable and fast enough for us to do this. Because we have to have a start and an end. That's one of the questions that we have to always answer when we are asked about how we have built the system. Does it mean that somebody can come in on Monday and on Thursday they are still coming for the continuation of that PHC visit? It has to have a start and an end. On the communication bit, I will have to have a look at how that was done. But I can see some people shaking their heads. A clinical encounter has to have a start and an end. Now, how we do it is how we need to agree. The people who have been doing level 4, level 5, level 6, them, they are not surprised because that is how it works. So, is the system fast enough to meet that need? That is the question on the table, and that is what DHA is working on. So on the communication bit, we will improve. I know we do usually release what we call release notes. I have had a problem with our developers asking them, does anyone read these things? Mahmoud, do you read? And you're the CTO, or you're the chief tech. Huh? Do you read those things? Personally, as a doctor, I don't think I would read those things. They are written first in a font that I cannot quite see. They are not pleasant to read. They are in a corner, you have to press a bell. So we are looking at how better to provide those updates. There's a time we were putting them in the WhatsApps. I don't think that's also a systematic, smart way of doing things. So it would be good to hear from the audience. How would you want us to communicate updates so that they reach whoever they need to reach in a timely manner, in a font that can be read and is pleasurable? Mahmoud, I would like that answer before I leave the podium. Okay? Yeah, I'll tell you when. So that's number one question. How do you want us to communicate so that we reach? Because when we take this issue of communication, trust me, we keep talking about communication, but I'm told, Doc, but they are release notes. And I'm like, can I first see those release notes? So when I saw them last year, I was like, who reads? So I've been doing a dipstick. And Mahmoud, you are my dipstick for this audience, and you're already shaking your hand. You don't read release notes? Who reads release notes here? Who even knows what I'm talking about? Do you read them? Are they nice to read? Huh? Okay, I've seen, no, if you comment, you might make me lose. Just note, yeah? So that now when I hand over back, as you comment, you give me how you'd want the communication done. There is an interesting question that came from John. He's wondering, what is a DHA person standing and we are busy saying, send back, what back, Nini, all the backs, what's happening? Why are people standing up and saying those things to DHA, yet the contract is between the facilities and SHA? So DHA is a service, look at them, look at us like a service provider for SHA. When I started, what did I say? Our work is to digitize the health sector. What does health sector include? I talked about pillars, or what people call building blocks. Healthcare financing is one of them. SHA is under healthcare financing. What is the government trying to do? We are trying to say people to specialize in what they do best and leave, and therefore we know, like from management books, specialization has got its pros. So that is what we are working towards. So SHA specializes in strategic purchasing of quality services, health services. DHA specializes in digitization of the health sector. KEMSA specializes in delivery, purchase and delivery of the medicines. Should KEMSA worry about the quality of the medicines? Who should worry about the quality of the medicines? Who should worry? PPB, Pharmacy and Poisons Board. Who should worry about whether this healthcare worker is legit or not? The regulators, okay? So when someone comes and says, Joyce, I put in my license number and it is returning expired, is it DHA? It's not DHA. Because what DHA has done is facilitate the communication between regulators and facilities. So DHA has provided that pipe. So we've connected to the regulator database and are able to tell the facility that Joyce is a legit healthcare worker or not. So if you find your license is expired, it is not DHA. We have also facilitated facilities to know who is this patient in front of them. Before those days, that issue that the gentleman from Meru has just talked about, and shouldn't be happening today because we are digitized, you are supposed to be able to know this patient has gone from here to here to here. Okay? You are going to be able to know that in a short while through what we call a shared health record. But for purposes of claims and submission of claims, you should be able, when we started, there was an issue. So under SHIF, we are allowed 2 dialysis sessions. So what we realized in Mombasa, somebody could go to Coast PGH Monday, they get their dialysis. Wednesday, they go to Jocham or something facility, and the facility could not see that this person already has gotten their 2 dialysis, and they continue giving the dialysis. Now we have since sorted that out. How do we do that? Because at the back, DHA does identity management of patients. We tell you legitimately, who is this? We give every patient a unique health ID. I'm sure today you all know about the CR number. It's healthcare workers actually who even tell me, you know the CR number, yeah, who use that is the unique health ID that allows transactions, health services transactions across all the health facilities using that one number. DHA also tells you whether this person is eligible for SHA. Before you waited for a card, sindio, NHIF times, and the person also had to produce an ID. Today, once I give you my ID number, you are able to know all the schemes that I am in. That is what DHA does. So you may not appreciate some pain points that we have sorted because now they're working. So the things that you're talking about is what we are also working on. So to the gentleman, John, that is why DHA is being told a lot of things to do with claims, because we are the ones who digitize. But how do we digitize? When it comes to the rules, SHA provides us the rules. Then we enter the system and we code the rules. There are places where we push back and ask SHA, if we do this, this is what it will mean. Go back and think about these rules that you've given us. If we do this, this is what it will mean to the patient. Go back and think about it. Then they come back and they give us an updated message, and that is what we code. Okay? They are the ones who say a rejected claim is a rejected claim. Is a sent back claim a rejected claim? Mahmoud, you know you're the only one answering. Is a sent back claim a rejected claim? Yes or no? Mahmoud, now you see why we need to also do sensitization. When I get sent back claims, should I sit and say, SHA has rejected my claims? I think you're now giving them, wapatie mwa Kenya, waambie ni no.
No.
So, thank you. A sent back claim is not a rejected claim. Rejected claims are the ones, once it's rejected, hatufungui, no conversation. But a sent back claim could be for many reasons. Many times it's missing documents, but other times it's also system-related issues. So DHA is aware of that, okay? What we are working on is how to sort a lot of those sent back claims. For example, we know that when SHA unleashes a rule and DHA codes it, the rule applies going forward. But sometimes the system, no matter how many times the devs have worked on it, we've tested, we've made sure, trust me, I sit in those spaces, then we see the system, it's like it gets its madness. It starts applying the rule retrospectively. Now, those are the things that we pick, and you will not even know. We sort it out in the system, okay? So we are also sorting that out, working with our SHA colleagues. On the 2%, yes, we communicated, we sent this communication of 2%. 2% is what? So when you go and open the digital health regulations, there are 2 sets of regulations. There's one called the data exchange, and there's another one called the health information management. So in the data exchange, there is a schedule there, I think it's second or third schedule, that has a fee schedule. And one of those is the HIMSS service fee. It is in the regulations. They were gazetted last year. Okay? We should have ideally started implementing sometime in November, but we've been pushing to ensure that the system is worth talking about. But what system are we talking about? The things that I have just described. HIMSS is about the utilization of the health information exchange in carrying out SHA transactions. So today, are you able to tell who are you treating legitimately? Yes or no? Are you able to tell which facility this patient, is in? Every facility has an FID. Are we able to tell whether the healthcare worker seeing the patient is legitimate? Okay? And we are able to consume from the product catalog. I think I saw one of the HPT team members here, Dr. Apio is right behind. He's been part of the team that has worked on the product catalog. We are waiting to have the shared health record that will enable the Meru gentleman to be able to see this patient has been from here to here and has been seen just today morning, because every clinical encounter, if you read the law, should be updated in that shared health record within 24 hours. But how will you update a shared health record if you don't have a digital system in the health facility? That is why I started my conversation on the biggest job that digital health is doing, beyond developing the health information exchange, is advocating and working with health facilities to digitalize. So the 2%, that is what it is. So for every transaction, successful transaction. So for purposes of the claim and consenting process by the health provider, that should this claim be approved to be paid, that is when DHA will get its 2%. So what does that do? DHA now becomes your partner in making sure that your claims, as many of them, are approved. So you're going to start seeing us being very proactive, working with healthcare providers in getting the system to do what it's supposed to do, but also having clinics. We already have that with a lot of facilities. The other day we were at Tenwek. Before, KNH are always calling us every quarter. Makueni County as a county arranges for clinics, and we have seen steady progress. Because sometimes it is lack of understanding. I will give you an example. Today, for the oncology patients, we have something called immunohistochemistry. How many times is immunohistochemistry allowed for a patient per year? Who knows? Nobody knows, Mahmoud. Nobody knows. It's once. But we have a facility the other day that wrote to DHA and said, why are we getting this error? The patient is in front of us here. What is wrong with you, DHA? And you know, when now people want to talk badly, they find out even my email, and I am in there, I am seeing. So, as a doctor, I first started by wondering, the last immunohistochemistry was carried out when? On 31st March. I think it was 30th March or 31st. And then we are now requesting for another one on 6th April, just this week. So I asked, why? Then now they started, oh, you know, it only allows for one marker at a time. And I was like, but are you guys aware that you're only supposed to use this in such and such a case? And that is why SHA has only allowed for once per year. They're not aware. So sometimes the things that we do is because of we are not truly understanding how SHA works. So SHA claim is not like the NHIF claim. And I'm about to finish. I'm just saying my last sentences. You're adding, oh yeah, you're adding. So SHA claim and this is usually my starting statement, SHA claim is not an NHIF claim. An NHIF claim was basically a financial claim. Yes, there were the obvious things. A man is not supposed to get pregnant, so we are not supposed to see a maternity, what is it called? Discharge summary, okay? A SHA claim is a health claim. It starts counting from the minute the patient shows up at the facility. Actually, for me, I like to say it starts counting long before the patient shows up in the facility, because if a patient shows up in the facility and first of all, even their SHA eligibility status is still upside down, then the conversation cannot even start. So the patient gets depressed. But for a facility, a SHA claim starts when you notify and say, this patient is Joyce, and they're eligible for for PHC, for SHIF, and for civil servant cover. That's when that claim starts. Then what happens in between? Before you finally go to that place where you are now attaching documents and invoice and everything, in between, you have to understand. And some of it requires some business process engineering, some understanding of what you need to do within your clinical flow at your facility, so that you are able to now submit a SHA claim. For example, we have seen facilities where a patient goes and they get in like a medical management case, then they now need to go to ICU. So they go, and then they move to ICU. But the facility calls me on discharge and asks me, sasa tutaingiza ile ICU aje? Unaweza ingiza ICU on the day of discharge? Yes or no? It can't. Sindio? So it means that facility had not understood that they needed to be a laptop or a tablet at ICU or that place, so that mutu anaingia ICU, the person at ICU anaingia na anasema huyu mutu sasa ameingia ICU. Okay? I have seen where I am asked, this patient we've discharged, but ni kama pre-auth yetu hatukufanya. You want to do a pre-auth on the day of discharge. Who can relate to what I'm saying? Who can understand what I'm saying? Yes. Now, it's just that we haven't even reached that place of strictness. One day the system will start asking, pre-auth means what? Pre. Not post-auth. Okay? So you've done a surgery, but pre-auth is being approved on, when is today? 9th, I'm a 10th. It's 10th, yeah? But the surgery was done on 8th. Okay? Then you are discharging the patient today. So hata mtu anaangalia kwa system, because now that's the other thing. Amidst there being a system, SHA for a while has included a human loop to just be double checking, because that's part of how we build the AI engine to strengthen it, okay? Double check that the system got it right. So all claims right now are going through a human being at the end of the day. So that human being, when they get it, they start asking questions. What came first? Pre-auth, surgery, or discharge? Yeah. So they start saying, but this is not possible. Pre-auth means what? Pre. Okay? Auth. So those are now the things that we are also working on. But once we have these clinics and the health providers understand, like KNH, we've seen a lot of improvement. Makweni, the county director, actually told me the nurses who used to keep on calling him to ask him that they be transferred to level 4, now they are happy working at dispensary and health center level, because they are seeing what their work is amounting to. Okay? So those are some of the, you need to understand what this means in terms of the claim process. So if you have to reform It is not the financial claim that NHIF was doing with a little bit of checking. This is a SHA claim, and it's different. And there is, you know, for NHIF, it used to take now the compliance officer to come to look for that file to open, then anafanya hara. Now there's a system that's checking all those things. So, and it's being improved by the day. So the 2%, that is what it does. And we are looking forward to seeing us improving on the quality of claims sent, but also improving on the system. So do not take it negatively. It's part of sustainable digital health financing. At the end of the day, we have to finance our own digital health. The biggest tragedy for any country is to have its digital health transformation majorly financed by donors. I think you have seen if that is where we were, I think you would know, where we would be today, courtesy of, was it February? When was it we started getting shocks? February, around there, last year, somewhere, okay? So I can talk a lot on biometrics. Is another question, Mahmoud, I want you to help me to answer. During NHIF times, biometrics was not failing?
It was failing, but the frequency was different.
The frequency was different. So, is it the scanners? What exactly is the problem? Because aren't we using the same scanners we were using during NHIF time? There was a special scanner.
I think the major difference here is the interconnection of data sets. Possibly that's where it's failing. Because in NHIF days, it was just one data set that was created beforehand.
Yeah, so in NHIF days, we collected the biometrics when we went to do the registration. So NHIF had its own biometric center, database, okay? Today, we hit the NRB to ask for your fingerprint. But the NRB gives us the name. Do we have a problem in identity management? Knowing who is the patient in front of us, unless it's when the system now has decided to misbehave. Do we have a problem? So why should we have a problem with the biometric? It's the same pipe, if you allow me to use those words. I'm not tech. But it's the same pipe, Mahmoud. Should there be a problem? So that's why I've asked, what scanners were being used during NHIF time?
Same, and we have more now, more options.
More options. So why is biometrics still a problem? So that's, I think, a question I'll take back, because I've been wondering, I thought NHIF were using biometrics. So forget about they were collecting their own data, because even us, we are going to start collecting for children, 7 to 17 years. But for adults, if we are getting the names from NRB, and we've been to NRB, at some point we went and told them, you people are the ones messing us up. And they showed us, how are we messing you up? These things work. 99%, yes. Even what we call edge cases, cancer, dialysis, the patients, renal patients, on NRB they work. They work. So what is it? Is it a change management process? What exactly is happening? So it would help if RUPHA also, Lishenga for once, so you do an understanding of this so that usitugonge sana. Find out for us what exactly is happening. And then I think I am on the communication. I think that's the biggest elephant in the room. I would like to get like 2 or 3 suggestions on how you think we can communicate on the updates. Asanteni.
Let's clap for Dr. Joyce.
Oh, and lastly, sorry, the SMS response. I've taken that. I will follow that up, because that's, even I don't respond to those to those SMSs. Gee, was I seen, was I not seen? It's a waste of my time. But the reason why we brought it up is because there was complaints to SHA that said, mimi nimeenda hospitali, nimeonekana, lakini sijapatiwa dawa. Nimeambiwa niende nikanunue dawa nje. Okay? So I think you'll see even the message we usually said, we say, umepatiwa dawa. umefanyiwa hivi. So it was part of getting the citizenry to also give their feedback. But should it be used to determine payment? I need to go and also ask at another level. Yeah, thank you.
Okay, thank you. Let's appreciate Daktari.
I need the answer for communication. Sitoki hapa mpaka muniambia how you want these things communicated.
I want you to have a seat here because you will be having a panel and that answer will come from the group. So let's appreciate Daktari.
Thank you very much.
I invite you to take a seat here. It will serve you twice. You will be resting as they think. Yes, and I want to believe that we have picked a few things, at least the idea or the mind that is behind the other side of the system, that is DHA, when we are on this other side of the facility. We may not agree today, but we still have tomorrow. But I want to bring in a panel that will help us understand better. She has tackled a lot of things on this other end, our pain points, but there are other things again on the other end. And I want to bring in some experts in this panel. And Daktari is already here from DHA. I want to bring our friend Eric from Cloudus. Please, let's appreciate Eric. Yeah, we've talked about the tech guys so much, so now here they are. And I also want to bring in the CTO himself, yours truly, Mohammed Amin. Because I will want Mohammed will moderate this one, but you will also give the RUPHA perspective. Sawa? Can change
the Thank you, Reverend. And good morning, everyone, once again. Good morning. Right. So thank you all for staying put and attending our Mjadala 2. We'll be very, very brief. Dr. Joyce has managed to answer a lot of the questions that perhaps would have ideally been answered on the panel. But I have just a few from myself. We are talking about this HMIS that is being quoted to be in the Act. We've heard her say there is a HMIS that potentially we are being charged for, right? So I wanted to understand this HMIS. How do our members get on board onto this HMIS? That's one. Then secondly, what timelines are we looking at? You mentioned about November last year, so that our members can get ready for whatever changes may come. This time around, it will not be short notice or overnight. So if you can share those sentiments, that would be great. Just to comment on communication, because that was directed to me. I think I would be speaking on behalf of everyone if we agree that before SHA, there was quite a bit of stakeholder involvement. The associations, the organizations, there were a lot of involvement during that time, but for some reason that sort of dissipated. So I feel like you guys are doing a lot of hard work in communication. And it would really help if we can bring back the associations, the organizations that are behind these members to trickle down this information a bit better. It will ease the workload of communication, and we can be able to deliver that communication last mile. So that would be my suggestion. And if the chair concurs then this would be our suggestion to carry forward. Thank you.
Okay, thank you. So thank you, Mahmoud. I think even for digital health, there was a lot. Lishenga, I know you came to several of the, Mahmoud also, you came to several of the stakeholder meetings, and you're right. That's one of the ways, at least from a digital health perspective, we want to revamp what we used to have, the Digital Health Technical Working Group. That's another space where you can come and give your ideas. But in terms of the associations, communicating through the associations, I've picked that up, and I will be intentionally now working to do that. Perhaps even create a group or a team, or I don't know, but where we push that information, we are available to take you through it, so that then you are able to take it down to the members. So if that's, I think that's a great idea. Okay, so okay, we'll still continue posting the release notes for the people who understand how to read them. Obviously, I'm not one of them, and they do have their audience, but I think the biggest picture is even the association leads should be aware of these changes and begin to anticipate and communicate. On the HMIS that you've just talked about, allow me to correct you a little bit. So the fee is not for HMIS. If you go and read in the regulations, and you're not the first one, I've had a task of trying to show the difference. The fee is for health information management service fee. Okay? And where do we get it from? So imagine that tariff. Like now, this one, I know if I ask, I'll get the answer. How much is appendectomy? Okay, let me ask, how much is normal delivery? The tariff? I can't hear from behind. 10,000, yeah? Appendectomy? Huku hamuko kwa hiyo level. 40 something, doc. It's 40 something K, okay? So for the cost accountants in the room, and for the people who cost their services, when you're costing a service, there are certain ingredients you put in that service. One of them is the space you're going to see that patient in. So you apportion rent to that cost. The healthcare worker, you apportion their full-time equivalent. True or false? You apportion several things, and one of those things, if there was no digitization, you'd also be apportioning a patient file, printing of a patient file. You apportion the data clerk's time in that costing, okay? So some of those things that would be done if you were having, there was no digitization, some of those things would include the health information management piece. So those things we are now doing digitalized. We are telling you who is this patient. We are telling you the eligibility of this patient. We've gone further ahead just to make sure for SHA that they can tell that this healthcare worker is a legitimate healthcare worker. And then in the fullness of time, remember what I started with, the future is we shall all have digitalized health facilities. So even the data clerk, I know right now you have hired many to sort out because you're doing retrospective data entry. Recall what I talked about, so that you can put in the SHA provider portal. But the day you digitize, then you come and we integrate you so that now it is not the SHA provider portal you'll be using, but using your HMIS, the Hospital Management Information System, you will be able to do identity management. Like you will be hitting somewhere and it will be telling you, it will be doing the same things that provider portal does. When that day comes, you will barely need a person to really handle submission of claims. A lot of that will be done on the back end within that HMIS. That fee is that, health information management. HMIS is another whole discussion. RUPHA, muko na RUPHA soft. Sindio? Sisi, hatukuji kuua RUPHA soft. Tunataka mutuambie when RUPHA soft is coming to the table, ndio now we start talking integration. Then, for the people who are doing hybrid and are still manual within your network, muonge story ya RUPHA soft. And there's a time I even told Daktari, RUPHA soft should not just be contained within RUPHA family. If RUPHA soft is a good HMIS, we have other customers within the private sector who are also looking forward to digitalizing, because huko
private sector, government, the most it will do is sit and give guidance. But we are not going to be able to finance, the devices that we are giving to public health facilities and also the EMR. So we want to see a stage where DHA, mimi tunakutana kwa a room, private sector network wako hapo, nyinyi mmekuja na RUPHA, mimi nimekuja na Taifa Care. Alafu tunaangaliana, tunamenyana so that we are pushing to have all health facilities digitalized. I hope that is clear. Huh? Timeline for integration.
Yes, for the transition. Transition.
For the timeline
transition from provider portal.
Okay.
The hard stop.
So, provider portal, we are supposed to have moved from it even for public facilities, but we haven't, because there are things that we are working on to make sure that shift claims can be sent optimally, okay? But do not wait for that time. Come officially as RUPHA and let us start doing what we have done for Nairobi West. Nairobi West can, through their system, are able to do things like identity management, okay? Now they are waiting for the last bit, the shift part, and then they'll be fully integrated. Because again, integration, we needed to have some guinea pig facilities, and we have progressed quite a bit. Now we have a less painful journey for like RUPHA. Yeah. So come early, because soon, one day, provider portal will be switched off.
Thank you. Mmesikia?
Thank you.
Utakuta siku moja hakuna provider portal.
No, lakini tutakuwa tumewaambia.
Right.
But do not wait. Come, we talk about RUPHA and how it gets integrated in the digital health superhighway. Yeah.
And on that note, you'll be very pleased to know that we also integrated with the HIE on RUPHA as well as provider portal. So both options are available, which we'll be showcasing in a bit. And on the bit of the manual work and the repeated work that provider portal presents, it's immense. I'm sure a lot of the hospitals here have had to go back and hire people just to sit on scanners. So I think this is a welcome opportunity if we can go digitalized. We also have another panel member here. Eric is representing Cloudus, and I would allow him to speak a bit about what the company does and how Cloudus brings to the table when it comes to claims management, digitalization, and specifically AI involvement in pre-adjudicated cases, so that these claims that we push through do not end up being rejected eventually. So, Eric, take us through kindly.
Thanks. Morning, everybody. Is it still morning? Good morning. Nice to be here. Thanks for the invite. So, Cloudus is a company that basically helps providers get paid. We understand that some of the challenges that providers have is over and above being able to claim on time. The bigger issues, and I think you've hinted at it, that the bigger hospitals don't really complain. It's more of when am I getting my money? We have claim periods that go in excess of 120 days, or 90 days, or 30 days, or 60 days. So what Cloudus does is we're able to look at the claims that you have, especially from the private sector. We haven't gotten to the SHA bit yet, but we are able to look at the claims that you have and pay you in about 72 hours, get you the money, then we will follow up with the, so we follow up with the provider, no, with your payer, in essence. So we are able to look at the claims that you have. In an ideal system, would be able to, once we're able to incorporate with SHA, would be able to say, this is how much SHA owes you. We've verified and validated all the claims that you have according to the scheme documents that you have, or the scheme cover that you have, inclusions, exclusions, and whatever, and then be able to pay you in advance while waiting for SHA to settle with us. Now, the bit that AI does very well for us, and that would be of interest, especially to this panel, would be a lot of what Dr. Joyce has said is true, that a rejected claim is not a denied claim, right? You need to know, or a returned claim is not, a sent back claim is not necessarily a denied claim or rejected claim. So you need to understand why you're getting this claim brought back. Now, what our system does, or what our AI tool does, it's able to tell you in advance, even before you submit. So it'll tell you things like, the pre-auth here doesn't work. You know, like, you're not allowed to do that. You're not allowed to charge bed space at this much. Or this is how much SHA will cover, regardless of what you're trying to bill. So we take all the documents that SHA has, all the documents that are involved within a scheme, again, the exclusions, the inclusions, what agreements you have with the payer, in this case, SHA, and we're able to say it meets or it doesn't meet. But we tell you this before you submit so that you can align to reduce the friction that is there in the claim process. So that by the time the claim is hitting SHA, it's a yes. So if we also, on the SHA bit, what we also try and do is alert you for fraudulent claims or for claims that are falling outside of what you would normally be able to settle, what you'd consider this is a problematic claim. And we're able to show that, because we also have a payer portal, and you're able to see, so if the payer would wish for us to go ahead and pay the claims, they would be able to see the claims that have been paid for and the reasons that this, if there's us denying or giving them warning, they would be able to see exactly why. I know we'll have a demo later on to kind of take people through this, but yes, yeah.
Yeah, thank you for that. Beautiful. I think that sets us up very well to talk on the next point, which involves DHA and the entire digitalization program. Essentially, we have very many companies that are interested to work in this healthcare space, but you find that it's very difficult to get into. A lot of the insurance companies that are existing right now do not even understand what FHIR is. So there's quite plenty to be done, essentially to unify the entire space, to bring clouders into the fold so that we all speak one language. We don't need multiple channels to send the same patient's record, for example. It will be very tedious for the hospitals, for the patient. Eventually, they're the ones to suffer the time that it takes. So I don't know what DHA has in store to bring companies like Clouders, like the insurance companies out there, into one singular platform.
Okay, so I'm still learning about
Clouders.
Cloud Earth, but I'll talk about the health insurance providers. So it's in our vision board. We know that at some point there will be the type of patient who has, like yourself, I'm sure you have Bupa and Cigna and a lot of, even Dr. Lishenga, I'm sure he has like 3. So oh, there's RUPHA 360. Oh, okay. So, so you have more than one insurance cover. And ideally, as you have rightly said, your health record should be able to be viewed, of course, with your consent, to whoever needs to view it for purposes of ensuring that you get your health care. So we have what we call certification. So for us, we build the highway. It's like the expressway. It's a digital public good. And we anticipate that health insurance providers at some point, you know, right now we know that they are peeping and watching how SHA will go,
But at some point, and we've already started getting positive remarks from some of them, they will come and say, we want to be part of the highway. Excuse me. Why? Because DHA will enable them to do something that they have been taking quite a while to do, like identity management, you know, and use of that cover in a health facility, you know, the same way we are doing with SHA. So certification of their systems is one thing that we'll have to go through, and one of the certification points that we are looking at is things to do with security, things to do with interoperability, and in comes what you called FIRE. Again, I am not an IT person, but I understand that is what enables systems to speak to each other. That's the language. So once they are certified, then we will be able to integrate them, and they will be part of the health ecosystem, the digital system. So definitely we are looking forward. So it will not come as a surprise for us. It is something that we have anticipated. We have also anticipated even HPT suppliers. They will want to know which are these facilities that are in Kenya, what are their orders looking like, so that they can be meeting that need, okay? So, but the bottom thing, as you've said, is we've defined from a digital health perspective, for you to play the games within digital health, you have to meet certain criteria. That criteria, you take your system through certification, we check it out for you, then we have you get onboarded. So we've already thought through that. Now for CloudUs is AI, and would need to really understand, yeah, how you're doing things. Already we have some of that inbuilt, such that when provider, okay, what the providers call it, it's errors, yeah? But we have inbuilt, because we are saying, by the time the claim leaves the provider portal, or the point, let me say the point of care solution, because HMIS is there, it should be close to 95% sure bet that that claim is good and will be approved for processing. That is what we are working towards too. So we are making sure that at the point of care solutions, we are putting in as much systems or engine or whatever it is that will tell the healthcare worker, look, that attachment that you have attached is wrong. Of course, when we have integration, such things should not even come up. That's why we are pushing for digitization. Yeah, thank you.
Just a quick question, Dr. Joyce. In and around being able to gather like health history for an individual, because I know the president famously said that there was one individual that had more than 10 amputations. And so the question becomes, where are we at with being able to reliably look at a patient and have their health history so that we're able to flag claims that do not make sense?
Yeah, so for that, 10 amputations and I don't know how many, I'll not comment on that. But recall at the start when I talked about a shared health record. That is the data portability bit that we haven't still gotten yet. So once we have that, we will then be able to tell all that information. So first, it will be advantageous to the patient, the client, because they will have their records in their hands on the Afya Yangu portal. They will decide who sees their health record, okay? Right now, we are at the level of thinking, should it be a flat health record or it should be in lockers, like the Indian system? Okay, such that if I don't want my chronic disease history to be seen, I put it in another locker and I only allow a certain caliber of doctors to see it. And then to the provider, they'll be able to log in and see that Joyce went to this hospital, she has this chronic disease, and this is what has been done for her. The reason why the so-called amputations or the so-called pregnancies that were being talked about is because the SHR is still yet to go live. And I'll give an example like for the pregnancy. Part of it was because of referral. Because right now we are still building. Okay? Our facilities are still not 100% digitized. I don't know what happens in RUPHA facilities. Okay? Because RUPHA Soft is yet to be onboarded onto the highway. The most we've been able to integrate is the things that are critical in conducting SHA business. So for now, we can tell how many dialyses you've gone through. That's part of identity management, but we cannot tell more. To tell more, we need the shared health record, which is what we are building.
Yep. Thank you. Hello? Yes, so you mentioned about fraud, and there's a specific number that has stuck in my head stubbornly. 165. I don't know if you guys can relate. It's a difficult task DHA is dealing with, and this 165 is the number of surgeries one person had done in a specific hospital in Nairobi in 1 year. And it's a big challenge because the same system is supposed to have, deterred this. It's a transition process for DHA. It's a transition for the hospitals, and I think you guys are doing the best you can do. It's an enormous task to carry 60 million people as healthcare and just transition it that fast. So I think we can applaud DHA's work and Dr. Joy specifically and Eric for the good work. Yes, Dr. Joy.
Yeah. So the 165, I like to always give context. At what point did it happen? Is it something that's happening today? Definitely no. Today, try and go for those surgeries. The system peaks. I've just given you an example of even immunohistochemistry. The other day, I picked another one for somebody attempting to go for another knee replacement. But we can see the system says, why are you going for another knee replacement unless it's another knee, and we start now following up. So at what point was this 165 coming up? At what point was the 9 pregnancies coming up? At what point was the amputations coming up? It was earlier, way earlier. Definitely today, you try that, it will not go through. And it gets better and better. Yeah. Thank you.
Thank you very much to our panelists. That is it from us. We'll be doing some demos, some case studies after this, but we'll allow Dr. Joyce to leave at our own pleasure. I think our members are really satisfied with your questions, your answers, and we look forward to good things from DHA. Thank you. Please, a round of applause to our panelists.
Hi guys, my name is Kuria Masharia. I'm from Clodas. I'm in charge of product design. So today I want to do a demo for you guys and show you what Clodas is all about. And I won't take a lot of your time, 7 minutes and I'm done. I'm not very technical. I have some sales and marketing background. So, but if you feel like I'm going towards technicality, just raise your hand. I'll tone it down, okay? So, for this crowd, I want to present these three parts, like the health provider portal, the operations dashboard, and the payers portal. So I'll go straight to it. So, like my colleague has just said, we are a system that comes in between the claims themselves and the payers. And our aim is to make sure that claims are as good as possible before they get to the insurance company. So for the providers, the facilities, we have a dashboard that is able to pick claims, either automatically because we have adding new claims, there is the manual way, and there is also bulk claims where we can pick. You download a CSV template, you fill in and attach all the documents, and then you upload it from your laptop or from your systems, and they go straight to our systems, our operation systems. Now, I just want to take you through a claim, the number of different claims that the dashboard is able to show back to the provider after our processing of the claims. So you can see here, I hope it's very clear. You can see that we actually able to point out the status of the claims, whether it has been flagged, it has missing documents, it's eligible, it's pending, all those things. And then, like my colleague said, there's some AI part of the system that validates and verify all the information that has been handed in. So you can see the AI confidence for all the claims that you've given, and the ones which are green, of course, are valid and verified and are able to be claimed. Now we can see more from a valid claim. So this dashboard here shows one claim that the claim amount is 50,000. The AI confidence is 75%, which is medium. The risk adjustment, the eligible loan offer, of course, and the processing fee that we are charging. Then we offer you an early payout. And when you accept the payout, we process and send it to your accounts. Now, like my colleague said, this will take at most 72 hours because we're using AI and patient history to see patient, hospital, and payer history to see what exactly comes together to give this confidence. Okay, so as you can see, we show all the approved, pending, rejected on the provider's dashboard, pending, AI flagged, and their reasons. Once you click any of this, you'll see the process where it's at the whole system and what's happening and all the loan offers. You can see the risk indicators here. Everything is provided for the provider so that by the time the loan is going to the payer, it is accessible. It's not hakuna kubahatisha, in other words, okay? So we can go next to the operations dashboard where now we come in as Clodas. So what we see as Clodas, our operations dashboard, we see like all the claims from all the providers and facilities that have been handed in. This, you can see we have the patient here, we have the provider. Of course, it's time, it's based on the time and date that has been, the claim has been submitted. And then the type, there's inpatient, outpatient, and the services offered, the amount, risk, and status, then the actions that are supposed to be done. So if we go to 1, we can actually get more information where we see all the claim data for the patient, which is broken down to the summaries, the treatment details, like you can see acute ischemic stroke, the procedures taken, the admission date, discharge dates, the billing breakdown, everything that have been used, and all the documents that were handed in by the provider. This part here is where the AI checks in, where it flags the reasons why the claim is risky. Then, like this one here, they say there's an extended ICU stay, and the cost is above threshold. And of course, like I said, these historical comparisons, the patient claim history, provider behavior patterns, and the insurance cost benchmarks. And then we have a decision panel where there's a human in the loop who comes in and says, okay, I want to approve or approve with condition or block this claim. And then it is submitted. On top of that, we have an audit trail of how the claim checks in and all the processes that it goes through. So the AI decision log here, depending on what exactly has been done, the AI and the human action log. We have a list of all the flagged claims to make things simpler, approved claims, the providers themselves. Sorry. And then we have the decision logs here, which give an analysis of the analyst that did all the decisions for the systems, everything that they've done. Yeah. So for let's say for the decisions that have been taken by the analyst, our analysts include us for purposes of audit. Sorry, the analytics are here, so we actually see the dashboards, all the dashboards that pertain to the claims that have been given, that have been handed in, and then, of course, settings depending on what you want to capture. Now I'll go straight to the payers portal, who are the insurance companies. All right, here for the insurance companies, they are able to get information about the providers who work with them in terms of the hospitals, the people who have insured with that payer. It is consolidated and put together in terms of hospital, and that's what the payer sees, or the insurance company sees. So, for example, for St. Mary's, they can actually see all the patients that have come in to any provider and handed in to the insurance company for St. Mary's Hospital. So here you can say the claims to be paid are 10. This is the value. It does an average, an approval rate, an average payment time. That's 3.2 days within the 72 hours that we claim. And then generally, this is a list of hospitals and patients that have handed in insurance claims to an insurance company. So we can go specifically to a certain claim for a hospital and see all the patients that are covered by that insurance for that hospital. So you can see again a breakdown, a very detailed breakdown of the submission date, the patient, the services, diagnosis, amounts, and we can go deeper and see what exactly was happening for the patient. And you can see there's a patient information, treatment details, provider information, and now our decision as Claudas as to why this claim should be given. So the risk score, we actually do the risk score, it is low. And it was approved, the amount of provider average, amount versus provider average, and then what we actually checked for us to decide whether this claim is going to be given or not. And then the payer can approve or decline depending on the reasons that they have. Or if they are not, they've not been convinced by the system, they can actually decline and give a call or contact us and let us know the reason why, and then we'll just get back to the provider. Generally, that is CLODAS in average. So any questions you can push, those are system questions. Okay? Yeah. All right. I hope you've been able to understand at least the flow of the system, of what we are trying to do. Thank you.
Yeah, thank you, Claudius. We'll do one more presentation before we take a break. So I know it's about that time, but just hang in there. This will be very quick. Okay, so I'm here representing RUPHA. I'm the Chief Technical Officer for RUPHA, and I'm also the Acting Secretary General for RUPHA. My name is Mohamud Amin, and RUPHA is our baby. So I will not go into details of what RUPHA does, but I just want to specifically nail the HIE component about RUPHA. We've talked about interoperability, we've talked about connection to the HIE. So today I'm just about showcasing that. And you can see here I have a form for registering a patient. This patient has been created an appointment for, but the key bit that I want to showcase is that from within the HMIS itself, you're able to pull in information to do with this patient, this specific patient. And as you can see here, we've pulled information from HIE, and we see that the beneficiary is Millicent, although the husband is the one that is the patient. And we can get a few more details about their membership and their coverage. You can see that there are a few details here, and that this cover is expired. So there are certain benefits of onboarding onto the HIE, that you do not replicate work, you do your work centrally without having to juggle a multiple number of systems. So that is just one of the use cases, but more specifically, we are able to send data to SHA and any other HIE-enabled system. For example, here, I will showcase one integration that we have done with Mama Toto, which is a farm access product. With Mama Toto, they also have a HIE integrated. And the beauty about our system is that we have the language for interoperability already built in within this system. So meaning that we do not need translators to understand or to talk on our behalf when we are communicating with different systems. So for Mama Toto integration, it was easy because we already connected with the HIE, and it's easy for us to send any information to Mama Toto and also receive the record from them. So for example, I'll just view what is cached because of connectivity. So for example, this was a record from Mama Toto, and you can see here we have quite a number of records registered in the HIE. You can see there's an encounter here. It's finalized. There's a consent that was taken for that patient. Coverage details. There are several observations that were picked from different occasions during their hospitalization visit. So this is where DHA is trying to take us, so that when a doctor requires information from their consultation room, they don't need to ask for files. They don't need to keep second guessing the patient. Are they telling them the right things or not? Everything is at their fingertips, of course with consent. Now, for our use case and today's case study, we wanted to showcase integration beyond HIE and integration into the provider portal. We understand currently everybody is using provider portal, and we saw the need to bridge that gap as well. As much as HIE is still catching up, we need to cut down the burden of work from our hospitals. So what we have done is integrate with the current provider portal setup. For example, here we have a sales invoice that we can associate with a provider portal claim. So by just finding that claim, I'm able to associate the sales invoice with a provider portal claim. Just waiting a bit for it to register. So as you can see here, we have a SHA claim ID and a SHA invoice ID already associated with this claim. So from this point onwards, what this means is that you will be able, or your staff will be able to do every bit possible that is done currently on the provider portal straight from your HMIS. Like for example, after associating, I can add billing lines straight from here. If I go to the claim tracker as well, I can be able to attach documents straight from the system. I'm able to amend, update references, and sync the claim if they're out of sync. So all this availed currently at the moment. As you can see here, we are tracking quite a number of data or details from the provider portal. This is quite significant amount of data that is being collected, and we are able to sync that for you. For example, currently we are talking about rejections, massive amount of rejections. We see that there is already inbuilt information within the HIE space. You can see here there are required documents that you must attach. And if you do not attach that, you get an 80% completeness score. So basically the system can be able to tell you how good you are doing in terms of claim processing. So in advance, you'll be able to tell, is this claim risky? Will it be rejected? So from that score, you can see 80%. And what is it saying that you're missing? You're missing line items. Of course, being a CS, there is no line item aside from interventions that is expected from you. So you can find that 80% is okay to submit. And you can also be able to attach, download and store all the attachments that you have done and sent to SHA. For example, in this case, we have all those records here, and you can be able to view them like I just viewed. You can click any of this, and you can see what was attached at that time. And beyond that, you have very detailed analytics that you can draw from it. For example, you can see what was totally invoiced, what is paid, and what is outstanding, and any other details. Around risk assessment, there's quite a number of computations that is done there, cash conversion cycle, performance metrics. If you're keen to details, then this is where you land. You can see compliance in terms of payments, how many claims were done, how many invoiced, what was paid, the payment rates, and all that. So it's giving you quite granular details as well as the payment trends, categories of your claims, and how they are faring on. Beyond that, we also have issue identification. Your claims can be identified with issues well in advance, and with this tab, you're able to identify key areas that your staff or yourself need to work on. So for example, in this case, we have about 1,000 claims that need to be worked on. And these are the different categories of which the system has identified as having issues or concerns. You can also drill down to which outpatient services or medical case, which category of claims have issues, and many more details around that. You can granularly see all your activities that you're sending to SHA. And beyond that, we have some reports that are generated weekly, like for example, this is monthly report. You will have an email every month showcasing the month's activities, and this is how it looks like. When it comes to your email, this is what you'll be seeing. You'll be seeing a snapshot of activities within that said month. There is also a weekly summary and a daily summary. All this comes to your email. So this is a sample of a weekly summary that comes to your email, and this is a sample of a daily summary that comes to your email. So in a nutshell, basically you're in touch with the hospital's performance and claim processing situation. Beyond that, we also have a transition analysis if you want to understand better how your statuses are progressing over time. This is where you come to, you can see what is high risk, what is low risk. For example, here you can see approved claims. We have approved claims maximally staying at approved for 16 days and an average of 1.9 days. So basically, when a claim has been approved, it transitions from approved to a different state, whether it is approved for payment or different state within 2 days. So beyond that, you can also see what areas you have high risks, where you have 64 days maximum, what you call stagnation in one status. For example, here we have automatic checks before, automatic checks done. We had 54.6 on average claim spending there. So basically that's my presentation in terms of claims management and intelligence around your claims within your hospital. And RUPHA doesn't stop there. We want to go to the grassroots. We want to take digitalization to the grassroots. And soon we'll be launching some. This is a CHAMA application that will put our presence right huko mashinani. I don't know if we can speak a bit about it. Thank you.
Good afternoon, everyone. I was not to be part of the presentation, so I would like to welcome you to our booth that I can explain a bit more what we do. But in a nutshell, we have RUPHA and RUPHA Soft to be able to, in a program called Mama Toto. And Mama Toto really is a program that enables is a digitally enabled pregnancy program for mothers from pregnancy until delivery. And what we are doing is exactly that. It's a hybrid care program. So we looked into the health system from the lenses of the mother and the lenses of the care provider to understand where are the challenges and what are the challenges for each. And for Mama Toto, we realized that that mothers are not coming to the clinics for various reasons that most of you may know, whether it's behavior, whether it's challenges of financing. And we said, what if we enabled that some of the touch points of the pregnancy journey are actually virtual. So we looked at partners and who to work with. And here we are working with indeed RUPHA Soft, RUPHA Facilities, and HealthX. HealthX Africa is a virtual care provider that has doctors. RUPHA has facilities, hospitals, and RUPHA Soft is the enabler. And through Mama Toto, a mother is connected throughout their pregnancy journey. How is that made possible? It is through the shared health records that Dr. Joyce was mentioning. A mother will show up at the clinic. The first visit, if you see, is very much virtual, because that's where we need to find out and confirm that the mother is is pregnant. But the second visit doesn't have to be physical, it is virtual. And how is that? And then so it is virtual, and you can see where blues are physical visits and red are virtual visits. On the back end, what we have done is that through a health information exchange, a mother visits the clinic and the data of the mother is entered into the EMR system. And as that data is connected into the health information exchange, well, the next time a mother shows up at HealthX Africa, through the doctors, as they consult into the clinic, the record of the mother shows up of what happened at the physical facility. So this enables that the mother's journey is very much continuous between the physical facility and the virtual facility, and it enables that if a mother is high risk, the care is very much personalized in the sense that the touch points are much more. Because of this way of delivering care, we have seen that we are able to pick risks very fast, because we've seen mothers who are calling the virtual care provider in the middle of the night to say, I am sick, I have a headache, I have swelling here, and it's peaked, it's preeclampsia. Immediately it becomes an emergency and an ambulance is sent and the mother is makes to the hospital and the mother and the baby is saved. We've seen mothers who are calling and saying, I'm sick here and here and there, and you're prioritized to go to the hospital, and what happens as a UTI is diagnosed and you get the appropriate treatment. What we have seen as results so far is that more than 80% of the mothers are getting 8+ touch points, where currently we are even hardly.
So ladies and gentlemen, let's give our attention to our panelists.
Do quality work from inception. And so when Farm Access came, we were very happy to partner with them. And we have been implementing the quality. We have been in the journey of quality. And we have progressed. Right now we are at level 3 safe care assessment, and we are working towards level 4. Hopefully within the next 2 months when our next assessment is coming up. Thank you.
Stimulate, create more understanding and more momentum towards adoption of quality in provision of service. Thank you very much.
Good afternoon, everyone. My name is Dr. Muganda Kendrick. I represent Strali, like the Director, Hospital Operation and Strategy. I also represent Tranquil Medcare, where I work like the Chief Operations Officer. I've been in quality for almost the same time as Dr. Dan Cura. And for us doctors who went to quality, it was not really that it was something we wanted to do, but we went there by need. So we were in the hospital. Sometimes you find that we're having a lot of litigation. Then what is happening here? Then it's like, go and do a root cause analysis. Then we train for root cause analysis. You go to the kitchen, you find that all the patients are having some infectious diarrhea. Then what is happening here? Then you go and learn about ASAP. Through that, then we have developed a passion for hospital operations, where we want to link in quality standards so that we are not reacting now. That's my brief journey with quality. I'm excited to be here to share some of the lessons we have learned the hard way.
Thank you all very much. I think we are headed for a very vibrant discussion, and I hope that the people in the audience will add to our conversation as we go along. I think just to set the scene a little bit,
thinking about the healthcare ecosystem as a whole and generally health in the global sense, I'd like to pose one question to you, Willie. Since PharmAccess is already putting in so much effort in terms of developing standards and assisting some of the facilities in gaining quality at a specific level, where do you see this as adding value to the system? What are some of the things that, why is it central to health service delivery as well as financing?
Thank you very much. That's a really good question. And quality is the fabric, if you put it that way. Quality is the fabric that makes health provision possible. So if you have a qualified doctor, that's one piece. If you have medicine, that's another piece. You have hospital beds, that's another piece. But when you have to put these three pieces to work together in a predictable positive outcome, you have to have measures and standards to control and coordinate the outcome. And that outcome has to meet a threshold that makes the recipient of that service willing to come back. Now, it could be willing to come back for care, vested effort. So quality is the North Star, the compass that ensures that you deliver safety and you deliver a quality outcome. Let me give an example. The global target now for maternal mortality is to come at 70 or...
There was a lot of discussions, very honest discussions among the staff, so that they could understand what we were looking for, why quality, and it has been a journey. And once everyone started embracing issues about quality, it became a lot easier because now they were able to understand why are we looking, what is this quality that we are talking about? Even as simple things like Willie said, washing hands. Why do we have to wash hands? You know, even a lot of engagement also with the customers themselves. Why do we do what we are doing? Why do we do it the way we are doing it? So it took a lot of, I can call it mind shift of, first of all, the personnel, the staff at the hospital, and also with the community so that they can understand where we are doing what we are doing. One of the things that, one of the outcomes that I can give as an example is like on the area of expectant moms. Once I know there's a way we handle the mothers as they come in, but we have to change a lot of things to accommodate or to cut down, especially on the waiting time. And that means that we have to do a lot of internal improvement of internal processes, how we handle the mothers and until from the beginning until the end. We have to do a lot of internal processes to improve on that. And what that has done for us is that we are now able to handle the mothers very fast through the system. They appreciate the services that we give. They appreciate the fact that they don't have to wait in the queue for too long. They appreciate the fact that even when they come for their delivery services, we are able to, now with the internal processes that we have worked on, we are able to assess the mothers and be able to advise them exactly what the next course of action is. And also, if like for one reason or the other, we have to refer a mother for maybe to a higher facility, then they are able to understand the reasons why we have to refer them. So we have a very rigorous process on how we assess the mothers. What that has done for us is that the mothers, they have a lot of trust on the service delivery. They have a lot of trust, and that has actually translated into the mothers referring other mothers. So word of mouth, a very strong component for that, because the mothers are able to say, oh, if you go to this place, you'll be assisted. Or sometimes we find that when they are coming to the clinic, they come with another expectant mother. So they are able to actually market the facility on our behalf, and we don't have to spend anything, because it's just because they were happy with the service, they are able now to market the facility on our behalf. And of course now that means that the business is growing. Yeah, thank you.
Oh, fantastic. I hope Olive Link will be with us for a very long time. And I think with that, I just want to segue to asking you, Dr. Muganda, in the long time that you've been working in assessment, and I think you've also come from the provider side as well, which is something we spoke about. Are there any other patterns you've seen in terms of how some of the facilities have grown in terms of the business performance, and also like Olive Link has already demonstrated that they've had more referrals in. Are there any other patterns that you've noticed through your journey in assessment?
Yes, true. And let me start by maybe making it clear. When we talk about quality in healthcare, we are talking about outcomes. Now, there is a way WHO defines quality. Then there is how we perceive quality. So on one hand, we have outcome. On the other hand, we have what is going to come in to produce those outcomes. Now, if you look at a hospital, we have different departments. What will be an outcome in finance department is not what will be an outcome in clinical departments. Now, thank God to SHA and digital health and the confusion that has happened in Kenya for the last 2 years, it has really exposed outcome in the finance department, where we are seeing things now like rejected claims, claims not being billed, and everything. If you analyze quality, long time ago, it was not keen in accounting and everything. So when we talk to now institutions, it was discussed here in the morning that institutions, certain institutions don't have issue with rejected claims. Now, if you go and check these institutions, they are institutions that have been invested in quality. So that is already a testament. I don't believe that's an issue at Malta, that's not an issue at Aga Khan, that's not an issue at NPSHA. But for us, upcoming institutions, there is an issue. So you see now, this is a financial outcome that is really causing pain to investors. So let me talk about some of the patterns that I've observed in facilities that have really improved efficiency and optimization along all the departments. So first of all the facilities that are going to quality, that are looking for quality, even if you move away from healthcare, they are interested into optimization and efficiency. Bottom line, everyone will tell you, I want optimization of these services and efficiency. So then how do we optimize? How do we make efficiency? That is now what SafeCare does for healthcare facilities. So the first thing that we want to do when it comes to optimization and efficiency, then it comes to the issue about sustainability. Will this facility be there tomorrow? That's what Eric talked about. Then we'll do the first thing that is called risk. Risk will check, are you having the right staff? Do they have licenses? Is the facility have licenses? We'll come up with the risk register. We'll come up with treatment and corrective action and mitigation at that level. I believe that will be SafeCare level 1. The risk, even fire, in case of fire, will this facility run? In case you don't have water, like a backup, will this facility run? Do you have a generator? So those are basic things that will make sure that the hospital will be there tomorrow. Then we go even to finance. What is your cash at hand? Are you able to pay salaries? Do you have all those things? So this is what quality will bring. Then we want to check the processes you have. Are these processes good? Are they serving the vision and mission? And this, if you have the process, do you have the infrastructure to support these processes? So these are some of the things we want to dig in, and we have case studies at every place, which I believe they are on SafeCare website. You can check them and do it. Then another thing we want to check, you have the infrastructure, you have risk. Now, the practice, what we say that Cura is following people to wash hands. Now, is this practice really what is written in these processes? Are they really matching? Or you have very nice processes somewhere in a shelf, and the staff are doing their own things. Now, how do we assess this? We want to look at the knowledge. Is there a knowledge gap? Then if there is a knowledge gap, what is your training plan? How are you training this staff to make sure that they are there? Then it comes behavioral modification, then it becomes a culture. Now, if you sort some of these things, you will retain your staff, you will improve your profit. Quality will never be expensive. So this is a nutshell I can explain about.
And I think I just want to expand on that. You said quality will never be expensive, but we have to have these conversations with the board and the management to be able to get them to keep reinvesting and sustain the gains that are being put through by having quality systems. So to you, Daniel, how do you have these conversations? How do you get the management to buy in, balancing with all the other competing priorities that quality is actually something we need to keep investing in?
Yeah, thank you, Elizabeth, again. That's a deep question, and I'm sure even us in the audience, we find ourselves having to make a case. Just before this session, I was talking with Mahmoud, and he was, we're discussing how he's pushing RUPHA soft and, you know, having to make that case to members. So, how do you make the case for quality? And I joined with Dr. Muganda in Aga Khan, and we found a moving bus. And but then when I moved now to MATA, and this is a new standard that was being introduced at the time I was coming. So some of the arguments that I found worked, and colleagues can also contribute, is one is the framing. Sometimes how the question is put or how the problem is put across can make a difference. So when we say, look, should we invest in a HMIS, for example, that will prevent confusion of patient identification, you know, lost notes and so on. Look at that cost compared with the cost of litigation, because from time to time we find ourselves as providers in front of the medical and dentist practitioners council to justify why did this complaint has come, and at that time what speaks is the notes. So are the notes available? And we say, oh no, you know, the floods came and they went with our file. So litigation. The other bit is efficiency, and clients do appreciate when services become efficient. So using the data within the system and showing that those places where quality has been implemented, there is efficiency. A small change, like for example, today when you come to MATA, you'll be tiered first before registration. See, it brings the issue of patient trust, what Josephine was saying, that I'm appreciated. You see, that's a value-adding step. I came to be seen, not to be asked, how are you paying, what is your, is it M-Pesa, is it card, you know, those kind of things. So do a small change like that. There is feedback from patients and say, you see, our patients do appreciate this small change you have done, and then you're given more resources to proceed. And starting with things that are, I would say, easier to implement, because there are some projects which cost an arm and a leg, others cost nothing actually. For example, the Kaizen improvement, just being able to sort things to, you know, sanitize, sustain, and you'll find it's actually the frontline staff who are quite excited. Another example comes to mind, having done Kaizen in one of the wards, and after finishing the project, staff did not want to be moved from that ward, because they said, here, even my quality of life has improved. I'm less stressed at work, I know where to get things, I'm admitting a patient, it takes me, we had the 2-second rule. If I'm looking for a Branla, count 1, 2, I found it. If I'm looking for, you know, this patient, things like soap, toothpaste, whatever, 1, 2, it is there. So life is improving. And there is a regulator. We are situated, our main hospital is in South B. We are neighbors with NEMA. And I think they tend to be a lot of our friends. So we have become friends, let me say. And So the regulator can come and also put a case for quality. We have the quality patient and quality bill that is in Parliament. That one for sure will change dynamics. We'll have to comply. But as Eric said, you have other, like the DOSH Act. So explaining to people the law. We have providers who, they have started a hospital, but they have not read the law to detail. So explaining to them and telling them being compliant is actually better than not being compliant. And that enters into part of the argument and enables the wheels of quality to move in the hospital. Yeah.
Excellent. So I think we've touched a bit on what is coming in terms of the fact that quality will no longer be a nice to have, but a requirement from the regulators as well. So I just want Willie to quickly comment on where he sees these accreditation standards such as safe care. How do they affect the relationships between our payers, providers, and the patients as well?
Standards are the framework of trust, if I simplify it like that. It is the meeting point between the various interests coming together. Take the example of KEBS. If anything comes into the Republic of Kenya and it is written in a foreign language and you can't tell what it is, sometimes you only rely on the stamp by KEBS as the reference point to accept that it is good. So the accreditation standards are the arbitration point, the meeting point where trust is established between the various parties. So take the example of a hospital and an insurance company. You're filing a claim, the insurance company pays. Will they pay because they believe you did something for their patient? Or will they pay because they believe you did the right thing for their patient? And you can only argue that you did the right thing for the patient because you are guided by standards and you are anchored down in a self-imposed requirement to deliver an outcome. So standards bind you to an intention to deliver an outcome. Now, that relationship is far easier between the insurance and the hospital because you could have a contract, you sign a contract, you say you'll do this, you'll perform according to that. There's minimum performance standards between a hospital and the insurance company. But what about the hospital and the patient where there is no contract? It's voting by choice. And that choice can be guided by what they hear or what they see or the previous experience. Woe unto you if it is by what they hear, because you never get a chance to defend yourself. The patient just dismisses you and says you are a bad place by what they hear. It's a very unfair situation. But unfortunately, this is what they received probably from someone who had it as well or someone who experienced it. So having accreditation and arbitration standards is what defines the terms of engagement and the rules of relationship in a way that builds the first or the starting point of trust. Let me emphasize, it is the starting point of trust. It is what defines the rules of engagement and the rules of that relationship. Without the accreditation standards, everything is a guesswork. And unfortunately, Kenya has, for the longest time, worked without accreditation standards in the healthcare space. SafeCare has filled that gap for about 12 years, done a really decent job, and we are very proud that many facilities have raised the value of their offerings from the low scores of quality to high scores of quality. High scores simply mean the probability of earning trust is very high, and the probability of building partnership with the clients or with other working partners in the ecosystem is very high. Now, safe care has been self-imposed. An institution chooses to go by that for their own interest and developmental journey. But when the government bill comes, it will be mandatory, and it's likely that it will tip many institutions to failure if they don't comply. Thank you very much.
Fantastic. So I think we'll need to wrap up our conversation, which I think we could go on for a few more hours, but unfortunately our time is up. But with that, I just want us to give a few parting shots, and I'll start with you, Dr. Muganda. In terms, because Willie has mentioned about the scores when you're looking at accreditation standards, and have you seen that making facilities a bit, how has that affected the attraction of insurers and investors into hospitals? What has been your experience?
So now, talking from an aspect of hospital operation now, not like an assessor, I want to echo what Willie said first. Actually, accreditation will build trust with the insurance and everything, because they will be, if this hospital has Joint Commission International, what they are doing is trustworthy, first of all. If they have ISO, what they are doing is trustworthy. If they are having safe care, what they are doing is trustworthy. But again, in my observation, I've observed that most of the hospitals who have up to safe care level 5, if you just look at their revenues, it's somewhere. And if you can directly link the safe care standards to the revenue, because you see, there is a structure, it's like a skeleton, there is much you can support. And which self-care comes, it will start with basic sustainability. You are sure that this hospital is not going to close tomorrow. So you see, that's already trust from your employee. You are going to retain employees, because the employees, they will know that they will have a job tomorrow. That will reflect on how they are going to treat clients. It means you have employees who are satisfied and they are treating clients. Then another thing which you want to see, it's when you want to attract funds, especially even if you want to work with the grants, they'll want to understand if you have a structure to implement this program. And some of the structures they will want to check first, there are things that we have been already addressed in safe care standards. So if you get yourself, you have been accredited, it means we have research, grants coming in, you are likely to be picked. Because for instance, let me just use the example, for instance, they want to do TotoSoft, what you have seen here, MamaSoft or what. They cannot come to a hospital if you don't have an HMIS, and these are some of the things that safe care is pitching for. So you have it, you are somewhere else. And then again, it goes to attracting now funds. You want to expand, you want to do other things. Now, these you can check. If you look at some of the things that the bank will ask for, there are things already covered in safe care standards. Because how will they give you grants and the hospital will be banned tomorrow and you don't have even firefighting, you don't have even, you cannot, you see, you won't be given grants. So they'll give you 100,000. Even our friend who was here with the processing claims and giving loans, he won't give you that money. So I will tell you that quality is not expensive. It's very cheap, and you can do whatever you are doing to achieve it.
Thank you very much for that parting shot. And then I'll go on to Josephine, and then Eric, and finally we'll get something from Daniel. If someone wanted to start this journey today, just wrap up, what would be the one thing that you tell them to start looking at?
Thank you, Elizabeth. If you were to start on the journey of quality, the very basic things that you need to have in place is, first of all, compliance. That is very key, 100% compliance. Eric talked about OSHA and all that, NEMA, that needs to be in place. The other thing is that, what is your vision? Yeah, you must have a quality vision of your facility, because that is also key. That is what will drive you into doing that. And also the investment that you want to do. you need to be able to like mobilize your personnel to understand what is this vision that you have. That is also very key, because they'll be the ones who will be doing the work probably. They are the ones who are looking after the patient. So you also need to have a very strong clinical team, because we are all looking at the clinical outcomes of the patients. So you must have a very strong clinical team to handle the patients for better outcomes. Those are some of the things that I can say now.
Okay, Eric, if you have something to add, I'll give you 30 seconds, and the same for you, Daniel.
Thank you so much for that. Personally, I would say quality is a journey, as we have said. And if I have to give an example of an institution where I come from, that is RUPHA Wainem Hospital, we've been in safe care for quite a longer period of time, from 2016, and all this time we've managed to have top level 5 safe care quality standards for 4 consecutive times. And for those institutions that are coming in and chasing quality, what I would say, it is a journey. And it is a journey in the sense that you have to do one thing at a time and make sure you do it to your best. For instance, if you want to have quality as a culture, some people define quality as a habit, some define it as a culture, some define it as the unlimited ability to put each and every effort every day for whatever you do. Me, I'll say, if it is onboarding of your staffs into your system, integrate quality in it, in the sense that you can have the quality improvement committee, in even the interview panels, integrate the quality improvement platforms into the appraisal form, so that when you are trying to also see the output of your staffs, their work assessment level, how are they performing in their departments, have the quality aspect of it in monitoring the progress of those staff. In that sense, it will trickle down all the way from management, from the passion, first of all, by the management, to onboarding of your staff, to appraisal of your staffs, and at the end of the day, it will be something sustainable. And the last thing I'll say to safe care, patients, we believe they haven't gained independence, and that's why they come to us, right? I will ask them to go outside the box. We have children institutions, we have the geriatric institutions. They are equally vulnerable, and I believe if safe care can push these standards into such institutions, I believe our elderly relatives, our children will also be very safe in those places. Thank you so much.
Daniel?
So my parting shot in 30 seconds, have a plan.
Perfect.
If you don't plan, you will fail. And secondly, when you have the plan, involve your staff with the problem that is most painful but easy to solve. Otherwise, if you decide to be a genius with 1,000 hands, when the genius is gone, the plan will fail. So the plan has to be from the ground going up.
Willie, would you like to say anything to what Erica said, or just give us a parting shot?
My parting shot is quality is one of those things that are not glamorous. They are tedious, it's annoying, it's very difficult. And most of the times, when your institution wins in quality, the people standing on the platform for the applause are not the people who've done the work. So it has to be a very institutional approach. Take a very rewarding posture on the people who enable the quality to thrive in your institution. Incentivize quality, motivate quality, shout about it, praise those who've done it, because it's a very unglamorous job, and if it is not given that attention, it falls by the way. You want that result, motivate, incentivize, celebrate it. Thank you very much.
Thank you so much. And with that, I'd like to ask the audience to give a round of applause to our quality champions. I believe we have unfortunately no time for questions, but if you see them in the audience, please come and ask us any questions that you have.
Thank you so much, Daktari, but 1 minute. I think there is a question that, one question that we'll pick. I think here, Maud.
Thank you so much. Very wonderful discussion. My name is Steven.
I come all the way from Kakamega. You basically answered the question that I wanted to ask, but there's another aspect of it that I would want to bring on board. There's a statement that goes that when the mind is blind, the eyes do not have value because we see through our minds. And in the healthcare workforce, we've had one major problem that has not really been properly addressed, and it's mental health. And I was just maybe wanting to propose in this panel, could we consider mental health as an aspect of quality improvement? Because if our mental health is not properly taken care of as healthcare workers, whatever processes, whatever plans, whatever structures we have that we want to implement, and the mind is confused, is disturbed, and is having many issues that were not being addressed, we may not actually achieve quality improvement practices that we envision. So would it be possible to maybe propose mental health practices for healthcare workers? Thank you.
Does anyone want to take that one?
That is why are staff leaving? Why are they not settled? And it's something which can be multifactorial. From my experience, we have seen some of them, it could be because of they are not sure of the job tomorrow. Another, it could be what Dr. Jura said, that it's the way the workplace has been arranged is stressful. So it's multifactorial. And from the standard perspective, it will be just at the satisfaction. But now at the facility, we need to dig deeper because the factors will be unique per facility. Sure. I don't know if I've answered your question.
I'd like to add something to what Steve has brought up. And the bedrock of quality is what we call a culture of safety. And when you say safety, it's psychological safety. So staff must feel that they will not be victimized in trying to propose improvement. And as facility owners or as those in charge, we must create that environment where our staff will not think their job will be at stake, or they will be put on the spot for reporting even themselves for something that went wrong. Once you have that, of course, we are not saying people should not be accountable, but there is nobody who goes to work intending to cause harm. And that's what we should understand, that when an adverse event happens, let it be an opportunity for learning. We should develop learning organizations, facilities that learn from the data they are collecting on incident management, and that is a thing, it's normal. So that will really help the mental status of our staff. Yeah.
Let me make a comment in favor of his question, because my colleagues here have answered it from the perspective of the HR design. But quality is very dynamic. It keeps on changing, and integration of new thinking has to happen. If you were born in my time, when we used to boil needles before injection, quality at that time was have some boiling water, have a fire and something. But it's changed to the point of have disposable needles now. If the world is moving so rapidly, the workload on an individual, the equipment on an individual, the capacity to absorb pressure on an individual is changing in such a way it can no longer be considered to be curable within HR practices, then it is reasonable to consider extracting mental health as an independent measure of quality and define standards for it. Otherwise, we could imagine we cure it from HR, and we really don't. Mental health is progressively becoming a standalone issue in our lifetime, such that if I resurrected my grandfather and told him today to talk to a counselor, he probably will ostracize me from his home. What kind of a weak man are we talking about here? But it's become a reality such that it is no longer enough to surrogate it to a standard practice. It can be a standalone issue. I defend your argument very strongly on that. Thank you.
panelists. I think that's a great thing. And that rejoinder actually has brought a new life into this discussion again. Please, let's give them another round of applause. I request my panelists, maybe if you can take a step forward, we take a group picture here before you leave. Yeah, our cameraman will fix that. Okay, just put it. Thank you so much. We really appreciate. That was great, and we really appreciate that information that you have just received. Thank you so much. And as they take their seats, there is one of our sponsors who we had not given an opportunity earlier. I can give them 5 minutes, and then we wrap up. I invite our chair to give closing remarks. Let's welcome Cosmos.
Good afternoon. Welcome to my presentation. I'm John Moridi from Cosmos Limited. And Cosmos is a local manufacturer. Welcome. So at Cosmos, we have 3 pillars. And one of them is Buy Kenya, Build Kenya. As a local manufacturer, we contribute fully to country's tax payment. We also contribute on the employment with over 500 permanent employees. So when you're using Cosmos product, you are supporting over 500 families. The second pillar is innovation. We have a 3 pillar, that is R&D, manufacturing and marketing. That's why our innovation is constant on production of cost affordable and quality product. The third pillar is cost saving. When you use Cosmos product, you save up to 50% of your patient medical bills, improving the patient compliance and better results on the treatment. So Cosmos products are of high quality, which are WHO and European PICS certified. And here are some of the products. I'll start with the CNS, 3D CNS. The first product is our olanzapine, Calmud. Then we have Calmex, Alprazolam, Diprex, Fluoxetine, Crotam, that is our new product, Levetiracetam. We have Pagaling, Pregabalin. Then we have Costapin and Tribes, which is vitamin B1, B6, and B12. So what is Costapin? Costapin is a combination of 4 products, 4 molecules, that is paracetamol 450 mg, codeine 10 mg, caffeine 50 mg, and doxyramide, succinate 5 mg. And why Costapin? For management of pains, could it be toothache, neuralgia, tension headache, postoperative analgesic following surgical dental, muscular and rheumatic aches, headache, dysmenorrhea, and migraines. The next product, the same Costapin, going at a lower up to almost 220 price. The next product is our Levetiracetam, Crotam. Currently, we have 250 mg in 2 strengths, that is 250 mg, 750 mg, and safe and steady for seizure controls. And why Crotam? Crotam, it's a broad spectrum in efficacy, suitable for all ages, that is from pediatric, adult, and elderly population. excellent in all bioavailability, having 100% bioavailability. Then high tolerability and safety. Minimal drug, maybe you're using maybe other drugs, there is very minimal interaction. Then there is rapid onset of action, making it steady plasma levels, allowing faster sensor control. That's our prices as well. The 250 mg going for $6.95, at 750 at $11.59. The next product is our olanzapine Calmode for management of schizophrenia and bipolar disorders, and also used for treatment of resistant depression. We have two strengths, 5 mg and 10 mg. And as well, very affordable. 5 mg going, a tablet going for around 15 bob, and 10 mg at 23 shillings. Then the next one is our antihistamines, Meftan Plus. This for adult, a combination of Montelukast 10 mg, levocetirizine 5 mg for adults and children above 12 years. We also have another one, the dispersible one for kids, 2 years to 5 years, most affordable combination in the market, and also palatable after you put it in after it disperses in a glass of water. Then we have our gut health. We have our PPY, esomeprazole 10 mg, Somicos. Then we have H. pylori kit, Helicos kit, which is a combination of amoxicillin, clarithromycin, and lansoprazole. Then we have our pre-probiotic, Cosflora, and our aminocidin, Dabro. The next one is our section for Euro products. Nuflex SR, and Nuflex Plus. This is a mirabegron sustained release. Then we have mirabegron extended release with the sulfinacin, succinate. Then Tamiton Plus, tamsulosin 0.5 with sustained release. And disotrient 0.5 mg, immediate release. And mostly for mirabegron overactive bladder, that is urgency, urge, urinary incontinence, and increased neurologic overly active, overactivity, given as a OD dose, both SR and Nuflex Plus. Then our Tamiton, mostly for treatment, management of BPH management. There are the prices as well. Going up, Tamiton Plus 45 shillings per tablet, Nuflex SR 54, Nuflex Plus 62. The next one is our intraconazole fungicos, the most affordable intraconazole blood in the market. As well, the price there per tablet at 46. The next one is febuxostat for uric acid management and those people with the gout. We have Fibron 40 mg and 8 mg. Then the next one is reducing the pill burden on the prednisolone. We have prednisolone 5 mg and prednisone for 5 mg. Now we have the 20 mg. This is a game changer. You reduce the pill burden, you improve the patient compliance. Then we come to the hypertension, the 3 pillars in the heart failure management, where we have our blood of glycid, dapagliflozin. Then we have Dicard, sacubitril, valsartan, Vino, Cavedro, and Tibina, tolesemide. We have an extended, for Dicard, that is sacubitril, valsartan, which is, which is an extension from 50 mg. We have 100 mg, then 200 mg. That's a complete one. For hypertensive and statins, we have telemicos, the triple therapy of telmisartan, amlodipine, and hydrochlorothiazide. Then we also have telmisartan 40 mg and hydrochlorothiazide at telemicos 80. Caditan is our blood for losartan. Then we have Caditan H, losartan, and hydrochlorothiazide. And we also have Caditan EM, losartan, and amlodipine. Then our blood, valinil, amlodipine, 5 mg, and amlodipine, 10 mg. Idulic, that's our blood. Idepamide, sustained release. Then Lipicos is our losvastatin. Avastatin, we have 20 mg, 40 mg, and 10 mg. Then for offering for novel anticoagulant and antiplatelet, we have our ATIZ, levaloxaban, 10 mg, 15 mg, 20 mg. We also have our clopidogrel, cosgrel, 75 mg, and cadesprin, 75 mg. Those are indications there for ATIZ, treatment of DVT and PE, and also for stroke management, prevention, and in annular arterial fibrillation. Then for management of diabetes, we have quite a number of products, starting with glucoset, the first oral semaglutide in Kenya, glycid, dapagliflozin combined with metformin, glucoel, that is vildagliptin. We have all the strengths from the 50 mg, and then vildagliptin and metformin, glucoel met 5500, 50/80/50, and 51,000. Then we have our range of metformins, glucomet 500, 850. Then we have the extended release XR, Diaglo, glyclazide, then our glypin met as well. So our first all semaglutide, glucoset, we have 3 strengths, 3 mg, 7 mg, and 14 mg. For management of type 2 diabetes and lose weight and gain weight. We have also dropped our prices there. It was recently approved by FDA, approval for weight reduction benefits, listed on the WHO Essential Medicine list, established by MACE benefits. That's 3 mg. Then we have the 7 mg and 14 mg. I will just dwell a bit on the dosage. So how do you take glucoset? It's a daily dose. You start with the 3 mg for 30 days for the body to adapt. It's taken very early in the morning in a fasted state, on empty stomach, that is, with the 120 ml of pure water. After you take, you wait for at least 30 minutes before taking any other oral medication or any other food. Then there is a 7 mg, this is the therapeutic dose. If we need be, you can titrate upwards to 14 mg for more effect. Then after 30 days, you can titrate higher to probably the 14 mg. They are available in pack of 10s. Currently 3 mg is 3,000, 7 mg at that 500, and 14 mg at 5,000, a pack of 10s. The most common side effects are nausea, vomiting, and diarrhea. So thank you.
Thank you so much. That was Cosmos. Let's appreciate Cosmos again. Our very good friend. We were supposed to have them in the morning, but we were abducted somewhere. Yeah, but thank God they are here. So I'm through with what I'm supposed to do here. My last assignment is to call my chairman, Dr. Brian, to come and give us his last remarks, and then tell us what is next. Thank you so much.
So thank you so much to our panelists and our presenters. I have a very simple task. First, to thank all of you, starting with Dr. Joyce. You've sat through the whole morning. We really appreciate, and even taken time to answer personal questions. This is much appreciated by us. I want to thank our panel from Farm Access, the quality team. Very, very insightful presentation, and I noticed that you involved quite a number of our facilities. They were on stage, and we really appreciate. I can see Olive Link, we are proud of you, the journey that you're taking, and I think it is lessons for our membership that this is possible. And everyone who has been here since morning, I hope you managed to get a cup of tea or something, but most importantly, you have networked, you've made connections, you've struck business deals, and you have learned something. So this is really what RUPHA conventions are all about: networking, catching up with friends, making business deals, and knowledge sharing. So this, we are very grateful for those of you who have been here since morning, since yesterday. Now, there are a couple of things that I need to announce. The afternoon session is dedicated for business. This is when you go out there, you meet the exhibitors, you meet the financiers, you talk to them, you explain your hospital needs to them, you network with your friends, try and make sure you come out of here with something. Even if it's not a purchase today, maybe it's a plan for next month, next quarter, you know, by the end of the year or next year. But this is a great place for you to make good and strong business relationships. So we are giving the afternoon for that. Unlike our previous conventions where in the afternoons we've had workshops and discussions, this time round our afternoons are for you to do interactions. So please take advantage of that. Take time to walk around, take business cards. If you've not been printing business cards, a key lesson is please make sure you have a business card for your hospital that you can leave behind. So that is number one. Number two, for our members who are here, yesterday we made an announcement, those who are not able to join us, that we will have our SGM on 20th of May. The purpose of that SGM is to look at our financial accounts and to elect new officials for the offices that fall vacant. So I know there are many leaders in this room. People who run businesses are leaders by nature. So this is your opportunity. We will be sending by email, according to the law, the accounts, the books of accounts, and even announcing which positions in the executive committee are available for those who want to offer yourself to serve on the executive committee of RUPHA. The third announcement, not really an announcement, just a comment. I have had quite a number of our members, especially the level 3 facilities, who have come to us and asked us about the mismatch issue. This issue of level 3A, level 3B, and 0 beds in the portal. We have, as an association, had a position on this matter since it came up. And I think the first time, and we were talking about it since October 2024. We even had several surveys where we were asking facilities that have KMPDC mismatch concerns to share information with us. We gave that information, and when the issue of deletion of beds came through, you may recall that we visited KMPDC, sat down with Dr. Kariuki and discussed the issue of Gazette Notice of 2021 and Gazette Notice of 2017. There were facilities which, under the 2017 Gazette Notice, level 3A facilities were ranked lower than level 3B facilities. So there were facilities which were 3B previously were considered higher rank, and the 3A was considered lower rank. But in the new gazetted notice for 2021, that was shifted. So in that notice, level 3A is the comprehensive hospital. It has inpatient, it has beds, and it has a theater, at least one theater. And level 3B in that notice is considered an outpatient facility run by a medical officer without any beds. That is the categorization. So a lot of facilities were affected by that shift. And what KMPDC informed us that they simply, in most cases, they swapped. So if you were 3A before, in the portal you were turned to be 3B. And if you were 3B before, you were turned to be 3A. And then the subsequent issue is they communicated that 3B facilities, by that Gazette notice, are outpatient facilities run by medical officers and they don't have beds. Now the reality on the ground is a bit different. We have a lot of 3B facilities that have inpatient and have maternity units. That we know. Now, why we met KMPDC was because the same Gazette notice of 2021 introduces a category called Level 3C, which is an inpatient Level 3 facility that does not have a theater. The only difference is that a missing theater. So a lot of the Level 3 facilities that have been reaching out to us are in that category. I have an inpatient unit, I have a maternity wing, but I don't have beds in the system. The beds are physically present. I have not put up a theater. So what did RUPHA do? One of the things that we did is we came up with a program for those facilities which wanted to upgrade. That program still exists. We still have a financed theater package. You can be able to reach us out. We have vendors here who are supporting us. They can give you a payment plan to put that theater in place so that now you have your inpatient, your maternity, and theater. So the conversation becomes, when can we get KMPDC to inspect you and move you to Level 3A? That's the first thing we did. The second thing we did, on the advice of KMPDC, we wrote to the Director General for Health, because it was not only Level 3 facilities affected. We know there are Level 2 facilities in the Gazette notice called dispensaries that have maternity beds. We still have Level 2s that have maternity beds in some remote areas. So we wrote to the DG and said, can you give a policy position of the ministry in terms of beds, hospitals, which don't have theaters, but they have maternity and they have inpatient? And the DG replied in August last year, and he said that he will take it up upon himself to discuss with KMPDC. We are waiting for that conversation to happen. So if you are a Level 3B facility and you have inpatient, maternity, but no theater, there are two things that are happening. You can upgrade, install that theater if your space allows. We will support you. And we will push KMPDC to reassess you and move you to 3A so that all your beds are recognized. Other than that, you have to either wait as we push also DG and MOH to finally recognize Level 3C. This is the position on that matter, but RUPHA is fully aware of this and we are working on it. So this is just to address that issue. Finally, those of you who have been here for the last 2 days, we felt as an executive committee that lazima mupate transport ya kwenda nyumbani. Sasa kama umekuwa hapa na huko kwa system, utapata transport. Now I've spoken like a politician. So, please make sure that you do not leave this venue before getting in touch with either George Mbogwa, our programs officer, or if you can find Cynthia Munene, our CEO, ako na bahasha yako, usitoke hapa bila bahasha yako. Make sure uko na pesa ya Uber ama ya kuweka mafuta kwa gari. But key thing, walk around, make business deals, network, let's learn together and make RUPHA stronger. Asanteni sana. We are still here tomorrow. So those of you who still have time tomorrow, we are still here. RUPHA is still here tomorrow. If you come as many as you have come today, we have a special session in the morning called the CEO's Forum. That forum is going to be for business only. So CEOs of hospitals and all these vendors you see here will come and sit with us and discuss how we can make our businesses easier and better to do. Other than that, thank you very much from the RUPHA Executive Committee. I want to ask a volunteer. In fact, I will nominate Madam Anne to come and pray for us so that we can move to the next session. Asanteni sana.
Good afternoon. Let's be upstanding. Our dear Heavenly Father, in the name of Jesus, we want to thank you this afternoon. Thank you, Lord, because you've watched over us. Thank you, Lord, for the sessions that we've had. Thank you, Lord, for watching over each and every one of us, bringing us far and wide, dear Lord. As we come to the close of the day, dear Lord, those of us who are traveling, Lord, may you watch over us. As we arrive safely, all the glory and honor shall come back to you. We thank you, Lord, for this conference, oh God, as we continue even learning and coming, even for tomorrow, Lord, we pray that you may be with us and guide us in all things. We thank you, Lord, for the committee members, those who are working tirelessly, give them energy to continue, Lord, even working for RUPHA, that RUPHA will be great for the glory and honor of your name. In Jesus' name we pray. Amen. Thank you.
Asanteni sana. Oh, please, and if you came with your vehicle, please get your parking ticket stamped so that part of your parking fees can be waived. Get your parking ticket stamped. There's a management office right outside, and a parking ticket pale wakuweke stamp. Asanteni.
Tunafanyia wapi interview? Tunafanyia hapa.
Hatutasumbuliwa.
Hapa tu. Sasa nyinyi mkisimama hapa, alafu sisi tusimame huko. Wewe kuja huko. Mna face huko. Hapo uko sawa, hapo uko sawa. Mtu akikaa.
Okay. Now I'm on set. Hawa pia ni vijana, let me start with you. Hawa ni vijana wa home. So you have to talk to them. Nisimame wapi ba? Okay, sawa. Sasa wewe wachana na hawa tu tuongee tu. Tupige tu story. Pige story. Okay. Nikikuangalia na hapa. Hapa. Okay. You want me to look at you? Yeah, just look at me. Forget about that. Good stuff. Good stuff. Ile. Kelele. Ina leak. Tell them. So basically what will happen, you just say your name, where you're from, what you do, and why, and then the subsequent question will be why you're here. Is this the first time you're coming for the medical expo? What was the experience? Tunamaliza game. Si hivyo tu. Haya, wamepunguza. You go?
Maybe I should start by saying I'm hungry.
I know. You guys have been sitting there for long. Okay. If you're ready, I'm ready. Okay. Just tell us your name, what you do, where are you from, and why are you here?
Well, my name is Richard Kariuki. I'm the hospital administrator at Lodwar Hills Hospital, who is a member facility of RUPHA. I'm here to attend the 7th convention, the 7th Convention and Medical Expo. And that's what brings me to Nairobi all the way from Turkana.
Acha. The 7th Convention Expo, Medical Expo. What has been the experience, being that today is the second day?
Good. I have sat here yesterday and today, and the experience has been nothing short of great. RUPHA is to be thanked for the packaging of the organization of the event, both from what we are able to see away from the main contributions. That is the discussions that have been organized, very, very insightful discussions on both the role of technology, on issues to do with quality, very, very insightful things on insurance and micro insurances, and sitting through those gives someone an insight of not just where medicine is going, but the evolving nature of the practice of medicine as a whole. And I liked what one of the panelists was doing, calling medical providers medical practitioners, actually, people that are practicing medicine, which is of course an evolving practice.
Oh, sure.
So it's been nothing short of a good experience. The discussions have been insightful, visiting the booths has been enriching, and of course you're able to do as our chair has insisted, being able to exchange cards and do some few businesses here. Yeah.
Nicely. Thank you so much. Ilikuwa tu hivyo tu.
Thank you.
Yeah. Nashukuru ma. Utakuwa kesho ama una were here for this particular convention, and then what was the experience like? What is the take home?
Okay. So my name is Stephen Ouko. I come from Kakamega County. I am a CEO and a founder of a facility called Allied Concierge Medicine. We basically do home-based care services to our patients. Why am I here? I'm here because it's visiting the city to be in a very nice convention like this. It is my first time to ever attend. I've been following the chairman in his social media handles, speaking more about SHA and such kind of things. And I believe being here, I have an experience that I would want to come to any more conventions that will be organized, because the discussions that are ongoing here are very good to help us as healthcare workers to understand what is needed in terms of our interventions for medical practice. Health financing has been a challenge for a very long time. The discussions here put your mind to a perspective to understand how you can position yourself as a healthcare worker, not just to give medicine, but to also understand what health financing is. And I think that's my take home from this meeting. Yes.
Thank you so much. Maybe next convention, are you looking forward to coming?
I am looking forward to come to the next convention, and I'm not just going to come alone. I will come with my whole team so that they can also get an experience to understand many things about health.
Yes, sir.
And we can also get an opportunity to get partners who have been here, see how we can do business and advance even to the rural setting where I come from. Yes.
Thank you so much, Mr.
Thank you
Uko.
Thank you so much.
Nashukuru.
Cheers.
Some data so nicely. say something? Come on, so basically, what happens? You look at me, forget about it. Oh. Answering with them. So basically, we don't want to interject. So
To my right side, sorry, you don't want to interject, yes? It's okay, yes. Sorry, am I interfering? By between, if you'll allow me, after talking about one product, I'll pause in between so that I rehash whatever I need to say.
It's okay.
For the next one, yeah.
It's okay.
Okay.
Are good?
All right. Yes, my name is Mohammed Ali. I'm the CTO, Chief Technology Officer for RUPHA, and I'm in charge of two products within the RUPHA stable. That is RUPHAsoft HMIS and RUPHAsoft Chama. RUPHAsoft HMIS is a unified platform where all our members and beyond the membership as well can benefit from efficient operations within their hospital ecosystem. It is connected to the HIE, which is the Health Information Exchange by the government, alongside other integrations that we have, specifically like LCT, Liaison, smart applications, and many others. RUPHAsoft is the same platform that the government has used to build their superhighway. It is deployed currently across the country in around 32 counties, and we are growing. I'll pause there.
Yeah, sure. Yeah, sure. RUPHAsoft in terms
you
of
want more on RUPHAsoft?
what does
Okay. Ready? RUPHAsoft is available for membership at a preferential pricing. However, anyone interested can still onboard onto RUPHAsoft. We have an onboarding fee and a yearly subscription based on the packages used. So we have a stratified package from enterprise to professional and starter, all with different pricing. We take about 2 to 3 weeks to train your staff and onboard you onto the platform. And that involves also hand-holding all your staff to proficient usage of the software.
Sure.
Okay. So next to Chama.
Okay.
So I need to think about this because the talking points are a bit far, I need to piece them together.
Okay.
So our second product on the stable is RUPHAsoft Chama, which is a software application, mobile friendly, that is meant to serve the rural setup very well in terms of running Chama-like operations. So, for example, your mama mbogas who convene at a routine manner, maybe monthly or quarterly, then they do have their table banking affairs that they want to operationalize or digitalize. So this is the window for them to organize themselves around a platform that is very friendly, easy to use, and beyond that, they are able to have full accountability, full visibility across their membership. Anyone who has this platform onboarded, their members can straight away log in and access all the details, their loans, their applications, where they've reached, their contributions,
what totals they do have. You know, no longer the case where people have to quarrel to decide how much you have in a chama or how much you're supposed to be paid. So that's our product to solve the problems of chamas of today. We are aware that Kenyans organize themselves around CBOs, around chamas, and this is how we get to mashinani. Rural Urban Private Hospital Association of Kenya is a chama, is a rural first association. Our window to the rural setup, to the rural makeup is through this platform. This is how we want to get to the rural folk.
Could you just please maybe highlight what is the reception or uptake of the idea of the chama, RUPHA chama? How is it?
So far, we are piloting it in 2 counties, and the reception is overwhelmingly positive. The software itself is given for free to the CBOs. There is no installation fees, there is no what you call onboarding fees. The only thing that we need from the membership is we have a few products around this table and that they subscribe to a few of them, and not necessarily the entire membership. So that's our starting point. For as long as the members, few of them have a product or 2 subscribed, that's fine. You are able to use this software for free.
Thank you. That was a nice summary.
Yeah.
Any live?
Imekatika. Oh, no signal. Oh, imekata. Ajui ndio umewaka wawita. Imekatika.
But it is recorded here. So you're here in window for bytes.
Hii live lakini haipo. Si live bado ipo.
Sawa, asante.
You notified me. You go live.
Oh.
I thought we were recording.
Hapana, chukua live.
You notified me, man. So I think I still. So go for bro.
Sasa wapi next?
360 toka hivi na ndio.
Oh, sorry. Acha tuweke hii. Haya, simama. Kwenye yako hapo. Utaniangalia. Sawa. Tata mic yake iko on. Uko sawa? Sawa. Unamsikia?
Be audible.
Audible?
Yeah,
Good,
like
good.
so
Like I'm talking to you.
Like ulikuwa prefect wewe nafikiri. Ulikuwa prefect.
Of course, for the longest time, eh? My name is John Odio Abuao. I work with the Liaison Group under Liaison Healthcare. Department is medical insurance. Today we want to talk about RUPHA 360. The RUPHA 360, it is an all-risk solution that we came up about risk and insurance, and it provides. RUPHA 360 is an all-risk insurance that provides insurance across all sector. When we talk about RUPHA 360 here, we are talking about medical insurance, pension, and other insurance like professional indemnity. Now, majorly it's on medical insurance, and on can I repeat again? Yeah. So when it comes to pension and administration, we help facilities under RUPHA to transform from tier 2 NSSF to pension plan, whereby they'll be able to provide pension under, they'll submit pension to Liaison and they'll be able to benefit it directly. When we talk about medical insurance, it is a cover that provides full insurance about health insurance. So here the package is for that covers up to M+3, that is member plus 3 dependents. And how the package is, for inpatient package it covers you up to 250,000. For outpatient is 50,000. This covers also comes with personal medical cover, whereby it will also cover you again with the dental and the optical of 10,000 each. When it comes to coverage also, it goes to an extent where it covers up to last expense. For the last expense bit of it, it can cover the nuclear family and also extend to extended family, whereby for extended family, it goes to cover for last expense for parents and parents-in-law, and these are all for parents. In pricing module, in pricing module, we get that we have for the nuclear family and for the extended family. So for the nuclear family, it is 22,200 shillings only, and this cover will cover you member plus 3 dependents. When it comes to the extended family, you will only add 2,500 for the 4 parents, that is parents and parents-in-law. And basically here you can see for the parents-in-law, you will add 2,500 shillings only for you to have a last expense for the parents and parents-in-law for up to a maximum of 50,000 shillings. This covers also has maternity cover in it, and it only covers for normal deliveries and CS delivery. So for normal delivery, it will cover you up to 40,000. And on how this covers member, when it covers you after SHA, so it's something that we came up so that it complements SHA. So on how the facility will benefit, there will be always uh, be be charging SHA, then the remaining amount it is when this RUPHA 360 cover will come in and take care of the balance.
So let me ask,
yes.
RUPHA 360, whom does it target, or who is it meant for?
Well, so RUPHA 360 medical insurance, it is meant for the public and RUPHA facilities, staffs, and any person who is working under RUPHA facility product, or sorry, RUPHA facilities. So for the public, now it is designed differently, and we will be able to share with you on how you can access those links. So once you reach us, we'll be able to share with you a link that you'll use to register as a facility or register in as the public member. On public member, this cover will cover you the similar way it's covering facility, but in this case, it will be able to cover you up to member plus 3 dependents, similar way it's covering for the facilities. But for this case, when it comes to the public member, it will work in different way, because we are trying also, as much as we are trying to target the public, we are somehow trying to avoid need-based clients, because sometimes this insurance fail because most clients that are going to be treated there, they're need-based. Somebody is coming in with their chronic condition today and needs to be covered immediately, and this will make this insurance not to work. So we have, as much as you know how medical insurance works for other private medical insurance, they have waiting periods. When it comes to the RUPHA 360, for facilities that are joining in today, they won't have any waiting period. So you join today and you'll start enjoying the benefits immediately. And when it comes to the public, we have reduced the waiting period, not the way the other waiting period for other insurers works, the private insurers. So normally, if you go to all these medical insurance, you know, for the personal insurance cover, they normally have a 1-year waiting period for chronic and congenital conditions. So these chronic are pre-existing conditions, and maybe for the newly diagnosed, they have a shorter waiting period. So for this one, we have reduced for the pre-existing conditions, we have reduced that waiting period from 1 year to 6 months. When it comes to pregnancy and related, also they normally have a longer waiting period of up to 10 months to 1 year, depending with the insurance company. But also this one, we have reduced it to 6 months. As we are going by through this journey, this waiting period will be reducing as we get more numbers. So this product actually, it's not only for the RUPHA members or facility only. It's open to the public at large. So once you are registered, we normally share with you the link. You click that link, you fill in your details, and it only takes like 3 minutes and you are done. Once you submit, or before you submit, it will prompt you regarding with the package you have selected, because we just have 2 packages. Do you want to cover nuclear family, or do you want to cover the extended family? So for the extended family, if you select extended family, it will generate an invoice for you. Once you pay, we'll be alerted, and we will forward those details to the insurance company to place you on cover. And after that shorter waiting period, for the public, you'll be able to start enjoying your cover. For the facilities, once you register, we have given you, we will share with you on how you'll be able to pay. So for the facilities, RUPHA facilities, we have given actually a very good payment model. We have 3 payment modules for facilities, those who are under RUPHA already. So the first payment module is cash and carry. You pay, then you are able to be placed on cover immediately. For the members who don't have cash right now, we accept installments. So you can pay with the liaison. We'll give you 4 installments. We don't charge you interest at all, whereby we calculate that maybe you have 10 members. They have selected the nuclear family. For nuclear family, per family is 22,500. When it comes to, for that, if you calculate for 10 members, that is 222,000. We will be able to split that 222,000 into 4 equal installments. Once you have paid the first installment, your member will start benefiting the cover immediately. Now, for commitment of payment, we'll need you to share with us a commitment of payment, and that is only you share with us either post-dated checks for those 3 consecutive installments, or you share with us the bank standing order, and your member will enjoy the cover immediately. So those are the modules we have, and due to that, you'll be able to start to enjoy your cover immediately.
Just tell us your name, what company you work for, and how has been the experience, this being day 2
Day 2 of
the
RUPHA.
exhibition.
So, hi, my name is Jackie Kinywa. I work with Microbiologist Africa, a company that is a distributor of laboratory equipment. So we are basically a laboratory solutions company. Physically, we are located along Thika Road, Garden Estate, B46, in case you will be interested to come see our products, see more of the products that we have brought. Or you can engage with us online. We have our contacts here. I think the camera will capture that later. But basically, this is our stand. We showcase products from biochemistry, immunoassay, hematology, pre-analytical products. So basically, those are the products that we supply and distribute around the country. And we are very glad to be participating in the RUPHA exhibition. It has been very enlightening as well. We've had some conversation, and also we've had the networking with some CEOs, some doctors who have promised also to indulge in our products. So yeah, karibuni sana microbiology.
From Ultramedway Solutions Limited. We deal with supplies for medical equipment, non-pharmaceuticals. This being the second day in RUPHA exhibition, it has been a one-on-one experience with our clients, with the hospital decision makers. We appreciate the management for RUPHA for giving us such an opportunity to interact with the end users and also showcase what we usually supply. Thank you.
What are some of the products you have?
Some of the products we usually supply include data equipment, maternity equipment, dental equipment, hospital furniture. As you can see on the display, and also the highlight on the wall is some of the products that we usually supply, and we appreciate that this platform is giving us an exposure to the end users. Thank you.
Scientific, we are a distributor of testing solutions. So we offer testing solutions to various we offer testing solutions to various sectors. So we are in the health sector, the healthcare space. That includes the hospitals and the laboratories. Then we are also in the food industry. So the food laboratories, we also offer testing solutions to that industry. So before any food leaves the factory, before it gets into the market, our equipments are used to test the quality of food that it's going to be consumed by the common mwananchi. Another sector where we are in is the life science research. So this is the research centers like the KEMRIs and the ILRIs. So when research is being done on various diseases, for example, our equipments are used in those labs to get to determine what diseases are going around and how they're going to be cured, for example. So that is in general what FNS does. We basically offer testing solutions in various sectors: food sector, clinical sector, and life science research sector. And today what we are showcasing here is the clinical diagnostic sector, where we are showcasing some of the equipments that are used in the clinical labs to test various solutions, including immunoassay and microbiology. So my colleague is going to take you through a little bit more in depth of some of the clinical diagnostic solutions that we are sharing today. CDG. Thank you, CDG.
Hello everyone, so my name is Rachel. I'm representing FNS, particularly the Clinical Diagnostic Department. So for Clinical Diagnostic Department, we represent two major brands, that is Biorad and Biomiro. So under Biorad, we represent machines that are able to do diabetes testing and HB variants testing, like the sickle cells and the thalassemias. We also have a division or other equipments that are able to do blood grouping and cross-match tests using the gel technology matrix. We also have the quality bit, whereby we sell third-party controls as well as EQA programs, and we have a software that enables you to do data management of the various IQCs. We also represent another brand called Biomirio, which has two major divisions, that is the microbiology and the immunoassay bit. When we talk about microbiology, we have solutions that are able to help you to identify the various microorganisms, that is the bacteria, the yeasts, the fungi, and such like. We have the fully automated system, which is like the Vitec, and also manual systems like the API strips, whereby you're able to do the identification of the various organisms. We also have another cluster of machines that is called immunoassay testing, whereby you're able to do the tumor markers, the hormonal test, the thyroid test, and such like. So So that is all about
Oh, sure.
CBG.
It's the second day of the expo. How has been the experience for you personally as an exhibitor? How's it been?
Okay. It has been a good experience. We've had various interactions with various people from different walks of life, the likes of pharmaceuticals, hospitals, labs, and such like. So it has been a good experience. Yeah.
Thank you so much.
Yeah. Thank you.
Mimi niko bado uko nyumbani. Ngoja kwanza umekuja kunini? Wednesday. Wednesday. Oh, hii nini hii gig? Oh, unakonga home? Unakonga mnagongenga hivi? Oh. Lazima msende namba yako kwanza. Hivi. Awanga tuko nyumbani. Jana. Huko job pia. Tuko pale na book yetu. Baada kufunga. Sasa bom, sabe? Still want more? Aí, pois sawa. Zaidi ndio ndio. Leo imekuwa sawa. Mike. Unajua na the problem ilikuwa na kamera moja. Alafu ile portability ni ngumu. Sasa sio kama hivi. Yeah, but that was in June. Instead of tukitoa mic mapana sasa ni brand anapofanya hii RBA. Na yeye my whole idea was afanye hapa. So wacha nitafute kufanyia sana niko tu ile. Unasema nini mzee? Ongea na kusikia. you are focused on. And another time, you can see
मैंने बोला ना तो मस्त हो अरे तुम यहाँ पे हो तो सही किसको जाके पता चला निकला है और
ufika huko. Hebu nipigie simu simuoni hapo.